deep in my soul, I know you are mine, and my heart belongs to you. Sweet memories keep haunting me, and deep in my soul, I know you are mine, and my heart belongs to you.
Dr. V.G. Mohan Prasad, Chairman of VGM Foundation, for this initiative.
And my special congratulations to Dr. V.G. Mohan Prasad for
doing an ERCP from Dr. Nageshwar Reddy because he is now in the US, so he couldn't make it. So please enjoy this video and then we'll have a discussion on this. Thank you.
Is to give an overview of what is happening in this area. There are vast advances that are occurring, so I can't cover everything, but I'll cover certain important aspects. ERCP was introduced in 1970s, and you can see the pioneers of ERCP in 1970s. Many of them toiled very hard and also were very successful in introducing the concept of ERCP and the concept of therapeutic ERCP. In 1973, Kawai and Carson first with the endoscopic village department removed CBD stones, thus opening the door for therapeutic ERCP. Since then, there has been a dramatic increase in the number of procedures that we do at ERCP, and also because of techniques and technologies have evolved. Currently, many of the things that we do have become very refined. What I'm going to do is going to present some of these, and all of them now are becoming evidence-based. First is regarding the use of metal stents in ICP. What is happening here is that both for benign and malignant diseases, the use of plastic stents are being very rapidly replaced by metal stents. For example, we should think that in patients with terminal malignant biliary obstruction, those who have a lifespan of say less than 3 months, we put plastic stents. Whereas those for longer lifespans, we use metal stents. So this has changed completely. We now say that all patients, irrespective of the nature of the disease, the advance of the disease, and the time limit of their lifespan, still require a metal stent. It's more cost effective, as we showed by this study from that. So all patients of malignant obstructive jaundice are now being evaluated with stents. Of course, there is a small group where diagnosis is not certain, where we want to do certain procedures like repeated RFA, where you can use plastic stents, but predominantly stents is taken over. The reason why this occurs is because of the technology that has improved in this area. We now have several types of SEMs that are available, the machine cut laser ones, the hand woven ones, which are much better. We also know, again, mainly from studies from Korea, and my Korean friends have done so much work in this area, and the Korean companies which have produced so many of these stents, that these stents are evaluated not only by the tensile or radial strength that they have, so that we know that the stent is very good radial strength it opens up, but also we know that low axial force or low axial strength is important, so that you can see the stent which is double woven like this has a low axial strength, stays longer and does not migrate. So these advances in technology have enabled us to use these stents in a variety of situations. Of course, we have always debated whether for distal malignant obstruction which use covered or uncovered stents, but now what we are doing is using mostly partially covered stents, like in this situation, which has the advantage of both covered and uncovered stents, so that migration rates are very low. And this Japanese study very clearly showed when these partially covered stents are compared with the other stents, that there is a definite significant less complications compared with uncovered stents for distal malignant obstruction. So this is our choice nowadays. Similarly, anti-reflex biliary stents are being evaluated, and the study from China showed clearly that if you have an anti-reflex flap at the end of the stent, then of course you can decrease the reflex and blockage of the stent. Potentially these stents have longer duration. We also now, I think, refined the technique of multiple metal stents for hilar strictures, and we know now, based on a French study, that you require to drain at least 50% of the liver to get very effective drainage, and sometimes this requires 2, sometimes 3, sometimes you have to put in 4 or 5 stents to achieve the same technique. Again, these stents can be put beside each other, or more commonly in our unit and elsewhere in Korea and in Japan, the stent-in-stent technique, the so-called Y stents, are being used, and this can be clearly seen here. This is a single stent through which 2 stents have gone in the Y technique, the stent-in-stent technique, which results in less cholangitis and probably better palliation. Now, in addition to putting metal stents in these patients, you are doing additional things, and these are called endoscopic adjuvant therapy. This could be in form of photodynamic therapy, radiofrequency ablation, brachytherapy, or radioactive stents. Of these, photodynamic therapy and radiofrequency ablation are becoming important. The reason why we are doing this is that the earlier is to just palliate this patient, but now we want better palliation. Better palliation means longer survival and also less stent occlusion, better quality of life. All this can be achieved by doing endoscopic adjuvant therapy, and photodynamic therapy has been clearly shown, based on this very famous study by Ottner in Germany, to prolong survival and decrease stent blockages rates. But unfortunately, radiofrequency ablation has many side effects, and in an oriental country like that, it's not very easy to use this because sunshine causes dermatitis, and these are very expensive. So what we have started doing, and this is a paper we produced long back, showing that radiofrequency ablation could be a new modality of therapy in these patients, which is equally efficacious with less complications than PDTA. And what we use is this machine which has come from StarMed, again from Korea, which is a generator which not only shows you how much time, usually 2 minutes, but also wattage 10, but most important, it's temperature controlled. So when we do this procedure, as probably will be shown it in live demonstration, we keep the temperature constant at 75 degrees centigrade so that best RFA occurs, and then we use this special type of LRA catheters which have got these steel electrodes from which the current flows, giving adequate ablation. And you can see very clearly here in our first publication how these cholangiocarcinoma patients open up even immediately. And again, you can see a video here of a cholangiocarcinoma in the hilar region, which you're seeing on cholangioscopy. And what we do is we use narrowband to clearly identify this villus carcinoma here clearly. And then we use this LRA catheter, which is passed on 025 guide wire as control studies from China, which clearly showed that in patients who underwent RFA, there is better survival and less stent occlusion. You can see here clearly that these patients have more stent patency and longer survival in those who have undergone radiofrequency ablation. And similarly, another study also from China showed the similar features, and there are now studies to show that if you add chemotherapy to RFA, these patients' survival is prolonged. Now, the side effects of RFA are very less, as you can see here. If it's in the mid CBD, you can get cholecystitis, and of course, hemophilia is the most important complication that we have to tackle. We also use the RFA in other situations, for example, in ampullary tumors, that is ampullary adenomas, with extension into the bile duct which can't be removed endoscopically. We can use radiofrequency ablation, and then we have shown that we can increase the survival in these patients. And this is an example of a tumor which we published in GIE with extension into the lower end of CBD. Using an RFA, we completely burn this tumor. Of course, you have to use a pancreatic stent in this case to protect the pancreas from heat pancreatitis. RFA can also be used for occluded metal stents, and this is again very clearly seen here, stent with tumor overgrowth. We can use RFA to clear it. So this is another technique we are using RFA at ERCP. Now switching gears and coming to another area, this is benign biliary strictures. The traditional approach has been what Costa Magna initiated, that is to dilate the strictures and progressively put in plastic stents, sometimes 5-6 stents to increase the diameter of the CBD, and then after 12 months remove all these stents. Of course, with the advent of covered metal stents, one covered metal stent is equivalent to 4 plastic stents, and therefore we did a study to compare whether both plastic stents are better or SEMs are better. And you can see very clearly from our study published in Gastroenterology that metal stents are as good as plastic stents, and we used it in patients with post-pancreatic biliary stricture, post-transplant, and post-cholecystectomy biliary strictures. In all these situations, the metal stents were very effective, and you can see from this study the most efficacy was for chronic pancreatitis, 80% resolution of the stricture, and follow-up on long-term after 5 years showed similar results. We recently published a study where we compared metal stents with multiple plastic stents given over 12 months, and you can see 2 groups of patients randomized to plastic or metal stents, and after removing this followed for 12 months, and you can see clearly structural resolution is similar with multiple plastic stents versus metal stents, but the number of ERCPs are significantly less when you use a completely covered stent. So the policy now in our unit and in most other units are that in patients with chronic pancreatitis with biliary stricture, completely covered metal stents put for 12 months may be the standard of care in these patients. But it's important to remember that you have to select your strictures properly, those less than 3 centimeters, and an absence of head mass in the pancreas. And again, this is a study you can see which came from Greg Cote and his group, showing that in all biliary strictures, completely covered SEMs resulted in a resolution of stricture much faster than plastic stents. So there's an advantage here. So what is happening in benign biliary strictures in 2022 is that from single plastic stents we have gone to multiple plastic stents to completely covered SEMs, and now we are getting biodegradable stents with steroids impregnated in them, and with this resolution of stricture and dilatation of stricture is also occurring. So in 2022, for malignant biliary strictures, we have moved from plastic stents to partially covered SEMs, or in case of hilar strictures to uncovered SEMs. Adjuvant therapy is given to most of these patients. For benign biliary strictures in 2022, we have moved from multiple plastic stents to covered self-expanding mesh stents, and we are going into biodegradable stents with steroid impregnation. Now coming to another area, which is endoscopic ultrasound guided, and this is I think important in the sense that radiofrequency ablation not only used for biliary malignancies but also for pancreatic malignancies. There are 3 of them available now, the Habib, StarMed and Irby. Of course, our experience has been with StarMed, and this is a study we published with our colleague Dongwan Seo from Korea, and you can see that using ultrasound guided RFA in patients with head pancreatic tumors which are very large, unresectable, you can get good significant reduction in size. Not only reduction in size, but you can also have reduction in the pain in many of these people. And of course, we are looking at survival advantage if there is any, but our proof of concept study has clearly shown that this can be used in these patients. Also, we have used RFA very successfully in patients with functional neuroendocrine tumors, and in the initial study and later we have now over 40 cases of insulinomas where we used RFA instead of surgery to palliate these patients and probably achieve almost complete cure. The other area where there has been dramatic advances in pancreatic biliary endoscopy is the introduction of cholangioscopy and pancreatoscopy. These have given us the ability to actually look into the bile duct or the pancreatic duct to not only do a diagnosis but also use therapy in form of laser therapy for stones to clear the ducts. And I think this is a major advantage now. Where I see the advantage also is in patients with indeterminate biliary strictures like this. We have 2 strictures where we don't have an answer. When we did a cholangioscopy, we could clearly see that on this side, the left side, there's a mass here from which we took biopsies. On the right side, there's a caseous material coming out of this swelling, which is obviously looked tuberculous. And when we took biopsies, you can see this was a B-cell lymph ERCP and standard brushing, what we do normally. In the second group, we directly introduced a cholangioscopy and took biopsies under guidance. And you can see the results very clearly that those who had a cholangioscopy had much higher sensitivity, higher overall accuracy. And therefore, our suggestion is that if it is economically viable in patients with indeterminate biliary strictures, instead of going on taking biopsies, brushings and so on, best is to do a direct cholangioscopy and take biopsies to get it a diagnosis. So I think the single operator cholangioscopy has revolutionized the approach in pancreatic biliary endoscopy. There is no need for radiation, direct visualization, tissue access, and of course, directed therapy. Another area where I think we have had is biliary confocal endomicroscopy, which was initially used for biliary cases, but now we are starting to use it more for pancreatic cystic tumors. And you can see here very nice pictures of pancreatic serous adenoma with the confocal endomicroscopy. Similarly, intraductal papillary mucinous neoplasm all have very distinct characteristic pictures with them, which we can make a diagnosis. And even in solid tumors like this, for example, in pancreatic adenocarcinoma, like this, we can get very clear pictures on confocal microscopy. Although the full capability of confocal microscopy is still not being used in our clinical practice, hopefully with technology becoming cheaper, with more companies coming into this area, we may be able to harvest this technique for better diagnosis. And of course, another area where there's been rapid evolution is in the field of managing pancreatic fluid collection, which went from simple multiple plastic stents to biliary stents to the so-called specialized stents. We no longer do direct endoscopic necrosectomies anymore, which was the standard earlier on. What we would do is to, in cases like this with large necrotic material, we used to do direct punches and go in after doing a balloon and then do a necrosectomy in these cases and then put in plastic stents. But you can see the large vessel here. The problem is if you injure vessels like this, it can produce very severe bleeding, and this is what happened in a case. We used to put stents and come off. But now the policy has changed, and we would rather not do this direct technique, because not only can you produce perforation like this with direct technique, but also complications like bleeding and so on. So what we now do is to use the short biflange SEMs, clear the necrotic liquid material, and then go ahead and do a necrosectomy. Several of these are available now, and you can see with this we can do a port necrosectomy at a later date, and this is an early series that we published with SEMS that came from Taewung company, and you can see very clearly how the whole walled-off necrosis collapses after this. So our choice for clear fluids, less than 10% necrosis, is plastic stents. If we have more than 10%, especially more than 30%, it's using one of these biflanged specialized metal stents. The reason why this is important is if you could do a direct necrosectomy, it can bleed like this, and therefore sometimes difficult to treat, although in this case you're putting in clips to stop the bleed. If you can't, then these patients have to go for surgery. But if you do a if you put in these walled off stents and then do a later necrosectomy, then it will be useful. But should we do necrosectomy in all our patients? And the answer is no. We do this step-up approach in our patients, where the first step is if the patient doesn't improve after the stent, we do a declogging. If it still doesn't improve, then we put a nasosuccinylcholine tube and hydrate and irrigate with hydrogen peroxide or saline. If it still doesn't use, then we do a direct necrosectomy. So you can see using this technique, majority of the patients are improving with the index procedure of putting a stent. Only 10% will require additional necrosectomies. And this again is a change of approach to patients with walled off necrosis. The whole concept has changed completely to more semi-conservative approach, and this has been proved by a recent paper in Lancet from the Dutch group, to a more aggressive approach that we're using later on. Now in patients in whom the papilla was not accessible for ERCP, we were doing percutaneous biliary drainage to drain these ducts. But now we are more and more shifting to endoscopic ultrasound biliary drainage, and you can see here very clearly that either you can do a rendezvous technique or direct technique. And also the pancreatic stent you can drain. So when pancreatic duct you can drain by this technique. So in cases where the papilla is not accessible to the endoscopist, we're using endoscopic ultrasound guided biliary stenting. But there's another concept now, this is only in inaccessible cases, but another concept where should we do this as a primary procedure. For example, in patients with obstructive jaundice, we can either do a hepatico-jejunostomy or choledochoduodenostomy endoscopically using ultrasound guided to drain. Of course, we have clearly shown that ERCP drainage not possible. US guided biliary drainage is better than PTBD for clinical success, adverse reaction and reintervention. But what about primary drainage? That is, papilla is accessible and still there is a concept that we can do endoscopic ultrasound guided drainage because it has less complications. And this was the study. There are now 3 studies available. The first one has come from Shyam Vadrajuru's group. We showed very clearly that in patients in whom one had a choice between doing ERCP versus EUS, EUS was better not only for adequate drainage but also for less complications. And subsequently, this Korean study also showed very clearly that EUS drainage as a primary modality is better than ERCP. So the question is, are we going to stop ERCP completely even for obstructive jaundice for malignant disease? Of course, I think we still require more trials, although we have these 3 trials and a meta-analysis to suggest a favorability towards endoscopic ultrasound. We require more trials because ERCP traditionally over the last 20 years has shown to be very effective in these patients for palliation of malignant obstructive jaundice. So I think it's not a prime time in this situation. Another frontier that we are attacking in pancreatic biliary endoscopy is the gallbladder, and this is again a lot of work which is coming from both Korea, China, Hong Kong, where you can do a direct access to gallbladder, put in these lumen opposing stents and subsequently go inside, remove stones or even do an ESD in the gallbladder to remove gallbladder tumors. So this is a very exciting area which is infiltrating into the area of a surgical domain, I think. Then coming to the last area, and this is the area where there's been considerable controversy in recent areas, that is the advent of disposable ERCP scopes. This came in because of reports in US, initially from Seattle, later from Los Angeles, of CRE, drug-resistant organisms causing infection at ERCP transmitted from patient to patient. It also went into public attention, and therefore there was a strong appeal to try and change the ERCP endoscope designs, because it was realized that the tip of the endoscope with the elevator was harboring organisms which were being transmitted from one patient to another patient. all the present companies, Olympus, Pentax, and of course Fujinon, have changed their tip now, putting tips which can be removed, cleaned, and using disposable tips. In fact, you can see in the Pentax here, a new tip with an elevator can be put in. With Olympus, not only can the cap removed, but a special cleaning device is now being advocated. And similarly, in Fuji, we have a disposable cap and a disposable elevator, which can be cleaned completely. So I think these are new designs, but there's more that the FDA demands, and this is a single-use duodenoscope. Two of them are now available, one from Boston Scientific Exalt, another from Ambu Cook. More of the evaluations have been done with the Boston Scientific Exalt, from which we also have an experience. And there was a randomized trial with single-use reusable duodenoscope, was a standard duodenoscope by Shyam Varadaraju and his group, published in Gut recently. They've shown that the overall technical performance and safety profile was similar between single-use and reusable duodenoscope. However, in difficult cannulations, reusable was better, but I think technology is improving. Soon we are going to get very good reusable, very good single-use duodenoscopes in which you can do it even in very difficult cases. The problem of course is the cost, and unless the cost comes down, this won't be used frequently. So when should we use disposable ERCP scopes? Of course, in logistics, if you want to do weekend cases where you don't have the full setup, or in low volume centers, this could be one option. In patients who have known multi-drug resistant organisms, it is better to use these single-use scopes. In critically ill patients who cannot withstand a scope infection, like transplant patients, ICU patients and all, we can use it. And of course, in those patients in general with a high risk of bacteremia, especially cholangioscopy, and we use
Sir, is it audible to you, sir?
along with cholangioscope in patients with large CBD scopes are very sick, who can't tolerate bacteremia, this can be used. So these are in general the indications, I think.
Okay. But
I think what is going to happen is, as more and more scopes are going to be available, more and more patients will request that we use single-use disposable scopes. It's very important to balance the cost in these patients. So what is going to be the future of ERCP with this type of scopes coming in? I think disposable scopes at present have limited use, but if the prices come down to say like $400, $500, then the use would increase dramatically, but we require to make them better functioning compared to the present scopes. Majority of the cases we still use the standard scopes, but they're going to get modified. They're going to get modified in form of elevator changes and also decrease infections. And I think again, this is something that we should look forward to in future.
Sir will be joining us live. Dr. Rajesh Krishnamurthy, gastroenterologist in Virginia and Seattle, is an advanced therapeutic endoscopist specialized in advanced ERCP and therapeutic EUS procedures. Over to you, sir.
Can we confirm that everybody can see me and hear me?
Yes, 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 sir.
Good morning, everyone. This is good morning from sunny Seattle. There is no sun in Seattle. Let's start with our talk today. I am Rajesh Krishnamurthy. I am one of the therapeutic endoscopists at Virginia Medical Center in Seattle. My talk today is on EDGE, or EU-directed transgastric ERCP, and how I do it. My talk can be basic to some of the senior people in the audience, but I'm going to keep it really basic and then go over some tips and tricks that you can try doing during this procedure. I'm not going to go over the data on effectiveness or adverse events of this procedure, as I feel it's out of scope for this 15-minute talk. That said, let's dive in. This is a busy slide. This is just our institution's
approach to patients with Roux-en-Y gastric bypass anatomy who need a ERCP procedure. Though the pathway looks complex, it's pretty simple, and I'm going to break it down. So if a patient who needs ERCP also has an indwelling gallbladder and needs cholecystectomy, in that case, we try to do a one-step procedure where we do a cholecystectomy in the OR, and in the operating room, we join the surgeons and do a lap-assisted ERCP. That way, it is one general anesthesia and everything is done together. If the patient does not need a cholecystectomy, or if the patient has previously had cholecystectomy, that is the situation where we have the dilemma on doing double balloon ERCP or do a edge procedure. So we have previously published on this metric, which is combined limb length of the pancreatal limb together. If that length is less than 150 centimeter, then there is a good success rate of reaching the ampulla with the double balloon enteroscope. If that is the case, we tend to lean towards a double balloon ERCP rather than a edge. Also, if the patient does not need a complex pancreatobiliary work, say it's a simple stone, we just need to pull out the stone, we try the double balloon ERCP. In the other situation where the limb length is really long, or if the patient, say, needs a complex pancreatobiliary work, say pseudocyst drainage or any sort of rendezvous work or PD stones and stuff, in those are situations we consider edge strongly. And in this decision of proceeding with an edge, we usually have a chat with our bariatric surgeons and the decision is made as a team. So moving on to a case that we recently had. This is a patient in his 60s who presented with a double duct sign, and there was a concern of pancreatitis with fat stranding around the pancreas. But there was a question on whether he could have an ampullary mass presenting as a pancreatitis. So we initially proceeded with a double balloon enteroscope, and in fact, we were able to reach the ampulla, and you can see the clips from the prior cholecystectomy. Unfortunately, I was unable to get guide wire cannulation of the bile duct, though I was able to get contrast into the bile duct. So we switched over to edge procedure after wire cannulation was unsuccessful with double balloon ERCP. So let's break down the edge procedure in a stepwise fashion. I like to think about it in 4 steps. The first step is identifying and filling the excluded stomach from the gastric pouch. The second step is the actual gastroscopy creation using the LAMS or the Autaxio system that we use in the US. The third step is securing the LAMS, especially in patients who need a single session ERCP where we either suture or clip the stent before trying to advance the scope into the excluded stomach via the newly placed GG stent. The fourth step is the actual EUS or the ERCP procedure into the excluded stomach and the duodenum. Okay, focusing on step 1, which is identifying and filling the excluded stomach. So what I typically do is I go into the GE junction, identify the GE junction, and advance the tip of the EUS probe 1 to 2 centimeters distal to the GE junction, and then start turning around the scope or the probe to look for the rugal folds of the excluded stomach. They can typically be identified by the thick muscularis propria of the stomach as well as the rugal folds, and many a time it looks like a starfish. So if you can find it from the pouch, great. But if you cannot see it from the pouch, it's still okay. Advance the scope further past the G junction into the jejunal limb, and then usually within a few centimeters into the jejunum, you can find the excluded stomach identified by the thick muscularis propria and the rugal folds. Once you identify it, then take a 19 gauge needle and then inject contrast into the cavity of the excluded stomach. And then once you do this, you should be able to demonstrate the rugal folds on the fluoroscopy. I have pictures to explain what I'm talking about in the subsequent slides. One practical tip during this procedure is sometimes the excluded stomach has a fair bit of bile or fluid, and it's easy to see the tip of the needle in the gastric cavity and inject contrast. Sometimes the excluded stomach is pretty dry and there is barely a few millimeters of gastric cavity that you can target with the needle. In that situation, I teach my fellows to overshoot the needle past the cavity into the opposite wall and then slowly pull back the needle while injecting contrast. The reason for this is if you don't overshoot the cavity, when the cavity is not big and start injecting, you run the risk of having a submucosal injection of the contrast, and it just makes the subsequent fluoroscopic interpretations a little bit more difficult. This step can often prevent that artifact from happening. And once this is done, we have demonstrated that, okay, the tip of the needle is in the excluded stomach and not the colon, which we don't want. Then now is the time to take the contrast syringe out and connect the foot pedal pump, like the one that we use for colonoscopies, and start infusing saline or water or methylene blue, whatever your preference, and then fill in about 200 to 300 cc's of fluid. Sometimes when you take access into the excluder, the access you get is kind of mid-body or even worse, body to antrum junction. In those situations, you will notice that as you're pumping water, the stomach might not distend. And that can happen for two reasons. One, it's possible that the water is going into the fundus, but you're not able to see the fundus in the window you're having. Fluoroscopy can help in that situation. Or more commonly, the more distal you go into the body of the stomach, the more likely all the water you're pumping is just going to go through the pylorus into the duodenum and not serving the purpose. In that situation, another practical tip is to either turn the patient left lateral so that the fluid accumulates in the body and fundus rather than going into the pylorus, or sometimes just put the head down and let the gravity do its work of letting it accumulate in the fundus and the body so that we can target. So at this point, we just took whatever access we could get, though we don't plan to go into the distal body with the ataxios. Our goal at this point is to get needle in and fill up the stomach. And almost always, now when you pull back the needle and pull back, you will be able to see the excluded stomach from the gastric pouch. If not, just at the GJ or immediately past the GJ and not deep into the jejunal. So these are just picture demo illustrations. So this is a typical view of the excluded stomach from the gastric pouch. You can see two layers of muscularis mucosa, the muscularis propria that is thick. This is just one good example where you can actually see a good cavity in the excluded stomach. This is not a difficult case to target with a needle to inject. But if this black cavity is small, that is when I was talking about overshooting into this wall, pulling back the needle and then injecting contrast so that you don't inject contrast into these walls and cause a mucosal bleb. So once you see the window, then you're poking a needle. The needle, you can see the tip is in the cavity. Now you're starting to inject contrast, and then on fluoroscopy, you can see that it's starting to demonstrate what looks like rugal folds, a little bit more injection, you can demonstrate the rugal folds really well, and you can see it trickling into the body of the stomach and to the ant. So now we know that we have accomplished the first step of accessing the excluded stomach. Now we switch the contrast syringe for the foot pedal pump of water or saline, and we start pumping. And you can see as you're pumping, the fundal area or the body fills up with contrast and water. Once we are done injecting or infusing about 200 to 300 cc's, your stomach usually looks like this. This is a pretty good size cyst for targeting with your ataxios. At this point, this is no different from a pseudocyst. In fact, it's a good size pseudocyst to go after. Oftentimes, before we start injecting or infusing the excluded stomach, we will ask for an entire gram of glucagon so that the stomach does not squeeze and get rid of the fluid contents. Getting to the next slide. We do the glucagon technique or the even for gastrojejunostomies. Sometimes we'll also ask the anesthesiology doctors to paralyze the patient fully and give us a gram of glucagon. This tends to help with the procedure. Not that important for gastrostomies, more important for gastrojejunostomies. So moving to the next step, creation of the actual GG fistula or gastrostomy. With the availability of 20 millimeter ataxios, we have almost exclusively switched to using the 20 millimeter ataxios. We have noted that with the 20 millimeter ataxios, the resistance between the scope when we're advancing the scope through the axios stent is much less compared to the previous 15 millimeter stent. And we typically use the freehand technique. What I mean by that is we don't pass a wire through the needle after puncturing to drive the ataxios over it. We have noticed that the freehand technique works just fine and less cumbersome. And then the other practical tip that we do is we almost routinely deploy the second flange. After deploying the first flange in the gastric cavity, we deploy the second flange within the scope and then slowly pull back the scope as we are pushing out the stent. The reason to do this in GGs is the real estate or the space in the gastric pouch is limited, and it's very difficult to endoscopically visualize the second flange deployment. So it's a better technique to deploy it within the scope and slowly pull out rather than trying to do it under endoscopic visualization. Again, illustrating these techniques, you can see that we have the nice cavity to target, and this is the tip of the ataxios probe that is hyperechoic. There is barely 3-4 millimeter distance that the ataxios has to traverse. And when we are using the ataxios, it's important that you don't tent the mucosa as you're pushing. If you're tenting, it means that you're pushing too much. Try more of a burn than a push. Burn and cut your way into the excluded stomach rather than pushing your way in. Once you feel that you're into the excluded stomach, then you deploy the first flange. Typically at this point, we get a wire into the excluded stomach after we open the first flange, so that wire can be used for the subsequent dilation. And then we deploy the second flange within the scope, and as we pull back, the stent tends to pop out, and then now we are done with the second step of GG stent placement. Now the third step is securing the lamps. This is usually done only in single session ERCPs. Say you were to do a 2-session procedure where you place the lamps on day 1 and bring the patient back for an ERCP in 2 weeks, you don't have to do the step of securing the lamps. But single session ERCPs are becoming more common, especially with the availability of 20 millimeter Axios. And in those situations, in our institution, we tend to either use a OTSC clip or an endosuture. Again, OTSC has become less frequent these days. We tend to go with endosuture as our choice one. Okay, so in this picture, you can see that we are deploying the 20 millimeter Axios. After the stent is deployed, we are dilating the stent with the 18 to 20 CRE balloon. After that is done, you can see the rugal folds of the excluded stomach. Now we take a deep breath. We are not in the colon, we are in the excluded stomach. And this is the time when we start securing the stent if we are doing a single session ERCP. So in this picture, you can see the 2T scope with the upper low endosuturing device attached to it. Typically, we do kind of 2 sutures to the between the gastric folds and the newly placed stent before advancing the scope. So this picture shows the scope passing from the gastric pouch through the Axios that was just placed. If you see closely, you can see the cinch from the endosuturing, and the scope is through the Axios into the excluded stomach. And when we traverse the newly placed stent, it's a good idea to have live fluoroscopy as you are making the turn and advancing into the excluded stomach. Once you are into the excluded stomach, it becomes less important to watch it the whole time. You can just do an intermittent spot every now and then of the Axios stent when you do a major move like advancing the scope long position or moving from the long to short scope position, just to make sure that the stent hasn't moved. In this picture, the scope is kind of in a semi-long position, and as I'm moving into a short scope position, I again take a spot and the stent has not moved, so everybody is happy, and now we focus on the cholangiogram part. So I have a few videos that is going to go through these things really fast. I know pictures don't do justice and videos tend to convey the information more clearly. So the first example is a patient admitted with a gallstone pancreatitis and jaundice. In the CT scan, you can see this calcified stone, that's the excluded stomach, being punctured with a 19 gauge needle. And then we have filled it up with fluid. Now the Axios is going in, first flange going in, and then you pull back the stent before deploying the second flange. In this case, we had space to watch it. And now after dilating the stent, this is an example where we are using the OTSC clip. We are not using them anymore. But then this was a few years ago when we had used the OTSC clip. Sometimes the clip can be causing difficulty to advance the scope, but it'll eventually go through, and then the ERCP was done and the small stone was removed. This patient came back after 4 weeks, but the disadvantage of using the OTSC clip is when they come back, there is so much mucosal growth, and you'll have to APC it before pulling the stent out. Now the DC cutters make it a little easy, but still tissue will have to be burnt. This is another case where instead of OTSC, we are just using an endosuture. So it's usually 2 sutures done through and through a full thickness fold and then into the stent. And then once that is done, then we advance the scope into the excluded stomach, and then the ERCP is completed. And the patient comes back. We use an endo scissor to just cut the suture, and then either using a snare or a rat tooth, we can grab the stent out. So the risk of gastrogastric fistula is another topic by itself. But in recent times, with the availability of XTAT device, it's almost like 4 clips attached to a string. We try and close all the gastrogastric fistulas after removing the stent with an extract device. And then we typically get an upper GI series in 1 month time to see if there is any clinically meaningful persistent fistulas. Sometimes we bring them back to close them either with an endosuturing or a OVSCO or OTSC clip closure, especially if there is concern of weight gain. So we have one more video that I would like to show. So stent dislodgement is probably the most dreaded complication during the procedure of doing an edge ERCP or edge EUS. This is something to just be cognizant and recognize when it happens. So recognizing that the stent has moved on fluoroscopy is probably the most important thing. Once it's recognized, we can usually take care of it. The problem happens when we don't recognize it and pull the scope. So once you see that the stent has moved on fluoroscopy, don't panic, don't pull out the scope. Either you've done it before so you can manage it, or call a colleague or a partner and take a deep breath. So I have a video on this, and let's go into that video. So this is a case where the scope goes into the excluded stomach via the axios. Everything seems to be going well. There is a duodenal stricture that we are dealing with. There is a pushing and pulling, and suddenly we note that axios is now in the stomach. So we place a wire after we are done with the procedure and pull back the scope. Now you can clearly see the peritoneum there. So put a rat tooth in, we have the wire still going through the axios. We pull and reposition the axios stent. It just takes a little bit of pushing and pulling, but then with fluoroscopic guidance, almost always you can get the stent to deform a little bit and then come into the pouch and then deploy it back in position. In this particular case, there was some pneumoperitoneum, but we admitted the patient, a few days of antibiotics, and we specifically advised the surgical team and the medical team managing the patient that some amount of carbon dioxide in the peritoneum is completely normal, and do not take the patient to operating room unless patient gets clearly peritonitic, and this patient did not. There are other instances where if this was not possible, you can always put a covered esophageal stent, say a 23 millimeter stent, and then you can suture it in place on the proximal end, and that should do it. We have not had a situation where we had to go to the operating room for this situation. But with the use of 20 millimeter stent and routinely endosuturing for single session, we have not had any issue of stent dislodgement. This particular case was when we used a 15 millimeter hot axios. With that said, this is a beautiful picture of our Seattle Space Needle, and I'm happy to take any questions that the audience might have.
Good morning, Rajesh. I hope you can hear
Good morning.
me. Yeah,
Yes, I can hear.
Yeah, Dr. Ganesh from Coimbatore. So an excellent presentation of the newer techniques which is developing in the US. A nice demonstration about the cases and the complications anticipated in that. Here we had a burden of the cost increasing with using the Vasco clips or the suturing devices. I'm asking one thing is about delaying the procedure. So if you can delay it after it's an elective procedure, you can delay it after 3 to 4 weeks so that the stent secures in place, and then you can pass the scope without stent getting dislodged. Have you had any experience of using such delayed procedures after taking as a 2 sessions? The first one putting the stent and leaving it for 4 weeks or 5 weeks and then doing it later. Is it advisable to cut down the cost? That's the only question about reducing the cost.
No, it's a very valuable question, and it's a very clinically relevant question. So unless there is an urgent need to decompress the bile duct, say the patient has cholangitis, or if the patient has some sort of a cancer that we are really worried about and don't want to lose another 3-4 weeks of time, or a 2-session technique is hands down the safest technique and also the least invasive between the two options. So if you have the luxury of waiting, say this is just a CBD stone without any complications from it, where we can have the luxury to wait, or say if this is a chronic pancreatitis and there is a PD stone that has been there for years, it's absolutely recommended to do it as a two-step procedure. Even 4 weeks might not be necessary, as even 2 weeks might be more than adequate. With those techniques, when a two session where you don't have to bother about securing the stent can dislodge, but like in fact it did dislodge a few weeks ago when I did a live transmission case to Korea, and the stent dislodged, but nothing happens. You just continue doing what you're doing despite the stent dislodging, then come back, put the stent back into place, and then you can switch to another EUS scope, and if it dislodges again, then you can keep pulling back and putting into place and nothing happens. So two session is the right way to do it if there is no urgency, because if the stent migrates, you can always reposition it, and I've not had a situation of a leak or peritonitis whenever it's done as a two session.
Good morning, Dr. Rajesh. This is Dr. Jayanti from Chennai. My question
Hello.
is, most of these patients would also have a cholecystectomy during the procedure, or gallbladder is often retained following the bariatric surgery?
So I wish I could say that we routinely remove gallbladders as part of bariatric surgery. In the US, it's not standard. There are some institutions that routinely do it. I wish everybody does it. And even in same institution, some providers routinely do it as part of the bariatric surgery, and some don't. The reasoning for that is not medical. It is just that whether you remove the gallbladder or if you don't, the reimbursement for the doctor might be the same, and that might be a bad reason, but a reason not to remove the gallbladder as part of the bariatric surgery.
So what would be the
some old schoolers?
So what would be the prevalence of CBD stone in such situations? Pretty uncommon, I suppose.
When the gallbladder is removed?
Retained, yeah. When the gallbladder is not removed.
I'm not able to.
If the gallbladder is not removed.
I don't think I'm.
The gallbladder is not removed. What?
Okay, I'm unable to give a number based on when the gallbladder was removed versus not, but I'm happy to email you with specifics. I can take your email from Madhura, and I'm happy to share that information.
Thank you.
Rajesh, one more question. This is about the primary stent placements. So normally we can get it from the gastric pouch into the gastric excluded stomach. But if you're not able to get the view, so you're going into the jejunum, do you expect more complications because they're going away from it, and the wall of the jejunum is much thinner? So when you put the stents from jejunum to the excluded stomach, do you expect more complications, or is it a routine practice that you can do?
So I'm going to take a step back. Oftentimes, you cannot see the stomach, excluded stomach from the pouch, but once you go into the jejunum, poke your needle into the excluded stomach, fill it up, put the head down, turn the patient left lateral, put in about 300, 400 cc of fluid. And if you want, in those situations, I might put in an extra amount of contrast into that fluid so that I see a big ball of contrast on fluoroscopy. Then once I'm done with that, I pull the needle out and then come back into the same pouch. And now suddenly I can see that excluded stomach. And then I can use the fluoroscopy at this point to guide or turn my scope a few millimeter directions, either this way or that way. And then you start to get a glimpse of the fluid. Once you get it, then you do whatever turning to do to get in position. And majority of the times, we will now have a window to do a true GG. But then, if that is not possible, we still routinely go with enterogastrostomy or jejunal gastrostomy and we still do the same things that we spoke about. As long as we have since switched to the 20 millimeter stents and the routine practice of endosuturing, we have not had any problem with doing single sessions. And 2 sessions definitely is even more safer in this situation, or more relevant for this situation, than a pouch to the excluded stomach. So I don't think it has gotten any worse adverse events. It's just that we're extra careful. But then the 20 millimeter and the endosuturing has been a game changer for single session. I don't think it matters if for a 2 session.
Thank you.
Thank you, Dr. Rajesh. With bariatric becoming more popular in India, so we might be facing many more of these patients, and so this is such a useful video or a PowerPoint to go through before we start any procedure. Thank you very much for joining us, and I know that we gave you only 1 week to, not even 1 week to prepare, just few days, and thank you for coming out with such a wonderful lecture. Thank you so much.
Thank you so much. It's my pleasure to be part of this event. Thank you again.
Thank you so much. Now we move on to the next lecture.
Next lecture is on newer frontiers in endoscopic suturing by Dr. Saransh Jain.
We'll start with the Apollo endoscopic suturing device introduction and its uses in morbid obesity treatment, closure of mucosal defects, leaks, fistula, stent fixation, and closure of perforations.
Dr. Saransh, the slides are not moving actually. Just the first slide is up. Yeah.
Now it's moving?
Yeah.
Okay. Is it now seeing? So when we talk about suturing, it's a surgical concept. So principles of operative or surgical techniques apply, which include asepsis, gentle tissue handling, effective hemostasis, maintenance of sufficient blood supply to tissue, proper use of surgical equipments, and accurate tissue apposition. This is an Apollo endoscopic suturing device, and here there is a helix which pulls the tissue towards itself so that a needle can transverse the tissue, and hereby we can suture the tissue in place. The needle toggles between the handle and the needle exchange catheter and is exchanged between them, and the tissue is brought between the prongs of the handle by using the helix. Once we finish the suturing, we drop the suture and we use a device known as cinch, which is a T-tag, which tightens the suture and keeps it in place, thereby closing the defect. So where all can we use this suturing device? The first and foremost indication is obesity, where it can be used for primary treatment of morbid obesity as well as revision of bariatric surgery. It can also be used for fistula closure, closure of mucosal defect, stent fixation, and perforation closure. Let us look into these indications one by one. For treatment of morbid obesity is the thing which has become a game changer in newer treatment of morbid obesity. Here we can use it for a procedure known as endoscopic sleeve gastroplasty. Here we insert the device attached to the tip of an endoscope, and through the mouth we go into the stomach. As shown in this animation, we start at the distal body of the stomach, at the incisura, at the anterior wall, moving on to the greater curvature and to the posterior wall of the stomach. We move back again to the anterior wall, creating a U-shaped pattern and tightening the suture, thereby leading to reduction in volume of stomach, both horizontally as well as vertically. A series of these sutures lead to ultimate reduction in body of the stomach. This is an video showing how we take the suture and the bites during a live case of endoscopic sleeve gastroplasty. We use the helix to pull the tissue towards us and toggle the suture between the handle and the needle exchange catheter, starting from the incisura, growing from the greater curvature to the posterior wall, back to the greater curvature and the anterior wall of the stomach. Once we reach back the anterior wall, we drop this suture and tighten it over a cinch to create the reduction in volume. Such sequential sutures led to ultimate reduction in volume of the stomach. This is a 3D rendition of a CT image showing reduction in volume of the stomach, and you can see we have spared the fundus, but the volume of the body of the stomach is severely restricted. This leads to improved satiation and satiety. These are the results of MERIT trial, which is a prospective multi-center randomized trial for endoscopic sleeve gastroplasty done in 8 US centers and reported a weight loss of 13.1% in endoscopic sleeve gastroplasty group, which was compared to 0.8% in only diet and exercise group. There were no serious adverse events requiring mortality, intensive care, or surgery in endoscopic sleeve gastroplasty group. So it is a safe and effective technique for weight reduction. It can also be used to revise previously failed bariatric surgeries. So what are the previously failed bariatric surgeries that can be used for revision by endoscopic surgery? We can use endoscopic surgery for sleeve pouch reduction. We can also use it in Roux-en-Y gastric bypass for outlet reduction with APC with suturing. We can also use it in mini gastric bypass for outlet reduction with APC and suturing with pouch reduction. We can use it for closure of mucosal defect. This is a case where endoscopic suturing was used for closure of mucosal entry in third space endoscopy. This patient underwent a G-POEM and the defect of G-POEM was closed using an Apollo overstitch suturing device. Here you can see instead of helix, we are using a rat tooth to grasp the edge of the sutures and using Apollo overstitch device to take bites on alternate edges of the sutures. Once we start from one side of the suture to the other side, we can sequentially take a series of bites to completely close the defect. And the entire defect can be closed in single suture, which is then dropped and tightened over the cinch. This closure was recently also shown in our live operative workshop done around 2 months ago. Next, coming on to closure of leaks and fistula. This is a case where I used endoscopic suturing for closure of large tracheoesophageal fistula. This was a young male with a road traffic accident and head injury requiring tracheostomy and had developed a very large tracheoesophageal fistula. As you can see, it is a very large, around 4 centimeter tracheoesophageal fistula with my scope easily negotiable into the tracheal side. The patient had failed previous OTSC application, covered stent placement, and was on peg feed. Here, initially, I roughened the edge of the fistula using a gold probe. I can also use an APC for the same. Once I had roughened the edges of fistula, I started suturing in a bursting fashion from the distal edge of the fistula. to the proximal edge of the fistula. Now you can really appreciate the width of this fistula. It was a very large fistula, but due to endoscopic suturing, we can approximate these type of fistulas easily. Once creating a base at the proximal edge of the fistula, we take another bite in the proximal edge to create a better base. It is important to work precisely in esophagus as the width is limited for us to take bites, and we do this procedure without the overtube. Once we have created the base in the proximal part, in the distal part, we again go back and create the complete bursting. After dropping the suture, we tighten this over a cinch. Once the suture is in place, we like to cover it with a fully covered stent for a few days and then start the patient on oral diet. We can also use the overstitch device for stent fixation as mentioned in my previous talk. Here I am discussing about the stent fixation in fully covered esophageal stent. You can see the stent. We can take a bite first into the mucosal fold, then into the stent, and then again we can tighten the suture over the cinch. A good study by Moin Kashyap in endoscopy showed that fully covered SEMS placement for benign upper GI disease, when we do stent fixation without any stent fixation, the stent migration is significantly more common in non-stent fixation group. Also, the rate of adverse events was similar between the two groups. So they concluded that endoscopic suturing is safe and associated with decreased migration rate, particularly in patients with prior history of stent migration. We can also use the device for perforation closure. When we use the device for perforation closure, it depends on whether it is a spontaneous perforation or iatrogenic perforation, and what is the delay between the perforation and the device closure. Ideally, it should be done immediately after perforation to create a sterile field. The site of perforation also matters because site allows us accessibility into that area, whether the perforation is clean or a dirty perforation. So AAGA practice guideline on endoscopic management of perforation in GI tract also recommend endoscopic suturing for closure of perforation in the esophagus, especially for perforation more than 2 centimeter, and endoscopic closure of gastric perforation, especially if the perforation is more than 2 centimeter. The 2 centimeter is important because other devices are difficult to deploy when the size of the perforation is more than 2 centimeter. And although colonic perforation is responsive to endoscopic suturing, the problem is accessibility. It is difficult to get the device in the right colon. That is why it was not given a strong recommendation. To conclude, endoscopic suturing is a welcome armamentarium in toolkit of endoscopist with wide variety of uses for both bariatric and non-bariatric indication. Overstitch-based suturing is technically feasible regardless of site and method of suturing, and it provides reliable suturing with clinical advantages. But you must keep the basic surgical principles in mind. Thank you, and I will be happy to take the questions.
Dr. Saransh, thanks for that wonderful talk, beautiful demonstration of the videos. So can we have some quick questions from the house?
I just have one question, Dr. Saransh, Dr. Madhura here. So when you're taking
Yes.
a bite through the tracheoesophageal fistula, how much of a gap will you leave if it is a very unhealthy fistula, or will you allow the, put in a NG or NG and leave it to heal or something, or what will you do?
So when we do tracheoesophageal fistula, usually they are chronic fistula, and these fistula are actually epithelialized. So first we raw the surfaces so that when we approximate them, they are able to hold to each other. And also we need to give them a healing time. So mostly only, we also give a covering esophageal stent so that the healing happens. And then after doing a contrast study in the stent, and then after removal of stent, then only we start orally in this patient. Also, I did not mention, but I also do a reinforcement sutures in such case. This was the first layer. I do one more layer, reinforcement.
Just wanted to know how much space you'll give from the site of the fistula. You'll give a gap, and like when you take the bite.
Yeah. So I like to take the bite from the edge of the fistula. Because I want to approximate the edges, because they are the places which I have roughened. So when they approximate, they have better chances of re-epithelialization.
There are no more questions, and we are actually.
Yeah, one more question. I have one more question. Yeah, nice presentation, Sharnas, Dr. Ganesh from Coimbatore. I just want to ask, the suturing is much easier in the spaces like stomach and distal, but more complicated in esophagus where they are very close to the large vessels. So how careful you will be to look into the bites when you're taking deeper, full thickness bites, avoiding bigger vessels in the mediastinum? Is it that a big issue?
Sir, please, when I did tracheoesophageal fistula suturing, I have both the spaces available to me. I can see the trachea, the esophageal space. So there is no risk of bleed from major vessels here. Although I was worried in this case that even minor ooze can cause tracheal spasm, because if the blood goes in the trachea, it can cause spasm. So I was worried about those ooze as well. When I am doing other uses of suturing in esophagus, like a Boerhaave syndrome, then also mostly what we do is we take the edges into the, I showed in another video where mucosal suturing was done of the G-poem incision. We take the edges inside the two prongs and then only suture. We don't do blind suturing like we attach to the wall and start doing suturing. We pull the tissue towards us, make sure that we have taken what we want, and then only we suture. So not many chances of getting major vessels inside.
Thank you, Sharnas. One more short question. Do you do APC on the edges to approximate easier and more healing? Do you use APC on the edges before closing the sutures?
For which case are you talking about APC?
Fistula, chronic fistula cases.
Yeah, fistula, always we have to do either APC or gold probe. We have to roughen the edges so that they re-epithelize when they come in contact with each other.
Thank you. Is there any other questions from the audience? Then we can pass it.
No, I think that is it. Thank you, Dr.
Good morning, Dr. Sarnash Jain. A small doubt. I am Dr. Gopalakrishnan from Tirupur. How much is this endoscopic suturing is effective in malignant esophageal, tracheoesophageal fistulas, in malignancies?
So malignant fistulas, usually malignant fistulas, we don't do suturing. In malignant fistula, basically there is a malignant growth which has caused the narrowing of the esophagus and also has created a fistula between the esophagus and the trachea or bronchi. So a covered stent is a good option here. Sutures don't usually stay because the growth is friable, and when we take the sutures, the growth will also come in the sutures.
Dr. Saranch, I really have to apologize. We are actually running a little late, so we'll have to end this session. And I'm sure we all enjoyed the session. Thank you very much. Especially the closure of perforation is something which not everyone talks about. Thank you so much. Thank you.
Oh, thank you so much for the invite.
We'll move on to the next talk.
Yeah, the next session, emerging vistas.
Went into an area of translation from viral hepatitis to various other liver diseases. Then suddenly we got vaccination as the wonder drug of choice, that we could prevent hepatitis B and hepatitis C, including the care that we take in transfusing the blood. And we suddenly realized that the entire hepatology is getting closed. And suddenly, we got the ultrasonologist report, here is the fatty liver. I'm sure that most of us in the beginning said, so what, fat in the liver, fat is there everywhere, and patient is very chubby, so why bother about it? Then suddenly we realized, look at the natural history, and it will be so amazing to see whether the entire world is what is called fatty liver, and that forms a small part of a large syndrome called metabolic associated disease of the human body itself. So let's limit ourselves to the metabolic associated liver disease, which was originally referred to for quite some time as non-alcoholic fatty liver disease. Why did this semantic matters? Because obviously he is not alcoholic. Somehow the word we don't want to use is alcohol. And now people are saying, why do you want to even call fatty? So there is a huge confusion. Does it make a difference when we call so many names? Now you could see that there are so many names, and cryptogenic steatotic liver disease, mast cell, then metabolic liver disease. There are people who have got metabolic liver disease without metabolic dysfunction. Let's say diabetes. He is not diabetic, but he has got all the, he is obese, non-diabetic. He is healthy, diabetic. He is healthy, non-diabetic, then he has got all the fatty liver seen. I think you got multiple combinations of all this. So we have all these issues on one side, and then everybody seems to be interested. The physician, the diabetologist, the gastroenterologist, endoscopist. You saw now, this seems to be the fancy of the world, that you do various bariatric procedures. And I was in the era of putting balloons, and then I burnt my fingers because these balloons cause a lot of complications. And we started with the sparge balloon, and then subsequently moved to the aileron. Still, anyway, thanks to the bariatric procedures, balloons go out of the way. Even the gynecologists are interested because they have obese women who incidentally have a gynecological issues like a polycystic ovary syndrome. They are young obese with polycystic ovary, or elderly, or obese pregnant woman, also again a problem there. The nutritionist is now evolving now with the diets, and you could see in a lot of advertisements on these nutritional issue and psychosocial issue, because they don't want to move in the public places when they are morbid obese. So I think the issues are small. So what does NAFLD with the name of metabolic associated steatohepatitis comprises of so many syndromes, but the most important is probably the cardiovascular disease, because the mortality in a metabolic associated steatotic liver disease is actually cardiovascular mortality. Even before the hepatic decompensation, some of them literally die, and we don't even tend to see them. You know, the other things like they have associated pancreatic, thyroid, and anemia related issues, and uric acid elevation, and of course the diabetes is the most important. So let's put it in a small this one. We have here a phenotype which is overweight or obese with a high body mass index to the tune of 30, 35, and something reported even 43, and they invariably are type 2 diabetic. And the third group, which is a star there, is sometimes you may not be overweight or obese, and the diabetes may not be prominent, but still they fit into metabolic disease because they evolve over a period of time. Why are we worried? We see lean people cirrhotic, virus negative, and suddenly we are surprised, what is this fellow? And this fellow is the metabolic liver disease. And there is endorsements. People called it with so many names. We are not able to get it still a final name as of now. You will see it later. So the transition, what was called, say about a decade back when we started our understanding of the disease, NAFLD to MAFLD, and one size still does not fit all, because we need a tailored approach, because you don't have the holistic syndrome in one patient. There is somebody who is lean, significantly diabetic, non-pancreatic, somebody obese and he is not diabetic, at this permutation and combination. We also saw lean people getting cardiovascular side effects, and look back, they have the metabolic aberration. So they developed a Delphi consensus statement with so much of this one. I can tell you ultimately it's a 7-layered conference. They could not even come to a proper conclusion. To see some of the current articles and press, a multi-society Delphi consensus statement on new fatty liver disease nomenclature. Honestly, if you read, they couldn't arrive at any good nomenclature. What is in the name? The new nomenclature or steatotic liver disease should be good enough to be or not to be. Is a change of NAFLD or MASLD driven by political correctness? I think there are multiple other factors, who is on the chair or the pharma-driven approach and all those things. So metabolic dysfunction associated steatotic liver disease, where does non-alcoholic fatty liver disease in the liver transplant recipients fit in? This is the current issue which has unpublished data is, will a fatty liver disease after transplant recur? The answer seems to be yes. So just because you have transplanted a cirrhotic liver and he is again likely to get the obesity, or the markers will still remain and he is likely to become again a NAFLD after this. So a 5-year follow-up of one group of transplant have shown that histologically they started showing all the metabolic changes in the liver. So we have now a complete overlap on these things. On one side you have NAFLD, on one side you have MAFLD, and there is an overlap. That means you have two syndromes which are overlapping. As of now, for us, a patient who comes to us with a cirrhosis of liver, with virus negative, with autoimmune negative, we try to put him. This is the real-time practice. Somebody comes, he is whether lean or whether he is obese, we'll see it later. But as of now, we want to call him non-viral, non-autoimmune, cirrhotic liver, quote-unquote, metabolic liver disease. Now, there is a good simple word probably, steatotic liver disease, but there is, look at the gray areas, the alcoholism 1 point. One confusion that comes is a metabolic liver disease man is taking alcohol. Shall I call it ASH plus NASH for him? So he is alcoholic hepatitis and non-alcoholic hepatitis. There was one study which tried to look at the histological overlap, but they couldn't give a very good picture of this overlap, because both will show fatty vacuolations, inflammation, necrosis and fibrosis, the standard events. So it is very difficult sometimes if you know that your obese patient is also consumes alcohol, and is there a safe limit for him? So again there is one study which showed a smaller dose of alcohol in a metabolic associated liver disease could be more hazardous. So we are in a crossroad that to decide whether it is all metabolic or whether it is also alcoholic. That overlap is significant. To add to the third component, we are confused about drug-induced liver injury. So we have a patient who is cardiovascular patient. He has got a metabolic liver disease in the form of elevated liver enzymes. He also takes alcohol and he says, I have been taking statin. Now this is again a fourth dimension added. Could there be a drug-induced liver injury in this fellow? Then we have looked, another small group is a cryptogenic steatotic liver disease, which is difficult to explain when you remove all the other factors. So what is the clinical components? Quite a large complex. All of this is known to you, which is there in any standard, this one. the abdominal obesity, hyperglycemia, high blood pressure and dyslipidemia, plus so many other things. These have sleep apnea syndromes, and so many other things have been polycystic ovary. And then HbHC co-infection can happen because of the population prevalence of around 1 to 2%. So, reassessing the causal relation between liver disease and cardiovascular outcomes seems to be very important. As I was telling, some of these people, they will not come to the GI unit or hepatology unit, they are still following in cardiology unit. So, we have requested our cardiologists to do ultrasound in all these patients as a protocol. Progression of non-alcoholic fatty liver disease and long-term outcomes is a nationwide paid liver biopsy showed that the histopathology progresses, in fact, and untreated NAFLD progresses. Is the time over? No. Okay, now let me go into another 3-4 minutes. The progression is very clear. So, we now look at what is called metabolic risk factor. You can actually calculate using these parameters. So, basically we know that this is a dynamic event, that you have an overlap between metabolic liver disease, associated alcoholic liver disease, or overlapping between these two, whichever is the dominant. So, these are some of our patients who present. Give me 2 minutes, be considerate, okay? So, these are some of our patients, you know, they look very healthy, but their ultrasound, and we do routinely MR elastography as more sensitive and is really cost effective. And this thing showed the significance of proton fat extraction in this, which otherwise is calculating the controlled attenuation parameter of the fibroscan. In these people, actually you cannot do a fibroscan. So, I don't believe fibroscan is a very important in these areas. Okay, what are the therapeutic challenges? Of course, everybody says lifestyle modifications. There are a large group of drugs which look at altering the metabolism. There are endoscopic procedures, I don't want to detail, we were just talked about it. Somehow the bariatric surgery has gone a little back, because we don't want to put it, we all looked at it as a mutilating surgery, and psychosocial interventions are very, very important, because 1/3 of the people who went into all these therapeutic modalities came back with the problem as fast as they went in. Weight loss, diet, coffee, there is a couple of articles, and the landmark article published in 212 New England Journal of Medicine, that the all-cause mortality of coffee drinkers is much less, and coffee has is very, very important, that probably we must ask our obese people to take coffee. Alcohol, we don't have a very good line, 30 ml, 60 ml, and somebody said 60 ml, 90 ml. I don't know exactly what is the right thing. Exercise, we have a lot of guidelines which are the real lifestyle modification. These are all articles which are also published, which you can go through. And ultimately what we are looking at, the calorie deficit that we are going to. So, you can actually correct the BMI using a calorie diet, and that we probably can use as a set goal, and everybody is given a time period by which they are expected to have this much of weight loss. So, there is a target which is kept on them. Exercise related interventions for the management of fatty liver disease and diabetes, there are already enough literature, and pharmacotherapy is probably evolving. I will quickly go through the number of drugs and then come to one particular drug which we were all impressed. Yesterday Dr. P.N. Rao spoke about vitamin E, and there was a very interesting discussion on Saraglitazar. Saraglitazar is an Indian drug. It is a PPR alpha delta inhibitor, which is supposed to have a metabolic intervention. We don't have an objective one, but I can understand, Joy also will tell, or all 4 chairpersons will, they are definitely prescribing Saraglitazar. So, one of my combination would be to use metformin, Saraglitazar and antioxidant in those people who have got a well compensated liver disease? You would give a comment on that. Saraglitazar was there, maybe we could have some discussion. Statins, one of our problem is statin has got side effects, but those people, interestingly, cardiovascular unit people who are using statins, their patients are less obese compared to the people who are not using statin. This has to be verified in your practice. Semaglutide, very interesting drug. Initially, it came as an injection, and it is an anti-obese drug, equally anti-diabetic drug. Now we got oral semaglutide. Now I think if I end my talk by saying we might take off a combination of semaglutide and saraglitazar, which have two dual pathways, controls the diabetes, controls the obesity, I think would be the future drug of choice which need to be explored. I won't talk much about this thing because somehow we have not very good experience. I think there was enough discussion on bariatric surgery. What is very important is patient-oriented outcome should be measured. The patients usually they get lost for follow-up. So this so-called PROMS is important in every disease and is equally important in non-alcoholic fatty liver disease. The patient should be absolutely monitored, and his weight loss, sometimes he says, yes, I lost 2 kilos weight, but he must have not lost anything. So it is a multi-pronged approach. A lot of associations have to work, patients, healthcare providers. There is an issue of billing, admissions and all those things, the pharma and regulators. I think it's a complex area which is coming up, and I thank the VGM and others for giving me this opportunity to give a brief talk.
Thank you, sir. That was an insightful presentation. Questions or doubts, if any, may be raised, maybe in a minute or two we can
very well presented, sir. Thank you. I just wanted to ask two questions. One, how does lean or NAFLD in a lean individual fits into the definition of MASLD? That is number one. And number two, how does defining MASLD changes the management?
Yeah.
The management remains the same.
Sure. That is what you give any name. Actually, you are interested in two events. One is the body mass index and the diabetes, and you want to address this by your lifestyle modifications plus or minus drug. You are the same. I was as confused as that. Does the name really matter? That's why even the topic is the same, MASLD or NAFLD or NASH. Now I think to call it much more easier would be SLD, steatotic liver disease. But then there is a problem with steatotic liver disease. Many things, even if you give anti-epileptics or antipsychotics, they have also produced fatty change in the liver. You see a lot of fatty vacuoles in this. So I think we probably the best thing to call is a metabolic associated steatotic liver disease. Seems to be okay for today, and again tomorrow there will be a meeting and then somebody will come out with a nice name, or we together can sit and give another name actually.
Dr. Arun Walson has done some study on semaglutide. Would you like to share some?
Am I audible?
Yeah, you are.
For a wonderful talk. I agree that metformin and saraglitazar should be given in patients with MASLD, especially if they are diabetes. But another thing I would like to add is what is your idea about SGLT2 inhibitors?
Yeah.
There is weight loss, there is no hypoglycemia, and it may be having a direct effect on MASLD also.
The problem is whether the patient comes to a gastroenterologist first or an endocrinologist first. So they have their ways of thinking. For example, insulin still seems to be a wonderful drug. Now, if you could actually, use insulin with any of the combinations, that should do more better than that.
Sir,
many of these patients have insulin resistance, so why should you push in more and more of insulin? The idea would be to reduce the dose of insulin and add on SGLT2 or a GLP-1 RS.
So that is what probably we are caught between 2020 is control of diabetes on one side and obesity on one side. I'm still get a correction from you saying that whether the initial control is by insulin and switch him to oral hypoglycemic or anti-diabetic agents is still a question. Probably the endocrinologist is now in, for example, you have weekly injection of semaglutide, which probably makes much more advantageous. I don't know. This is a area of discussion. I agree with you.
Sir, is there any role of oral semaglutide in managing NAFLD and NAS?
That's the current.
Number one. Number two is what is the role of alternate day fasting? Dietary restriction for management of NAFLD or NAS?
Yeah, there are a lot of papers on alternate day fasting. So I just want to, all these things work actually. Let me tell you, if your target is 10% weight loss in 2 months or 3 months, you set a goal actually. What is the way? They all work. So I want to tell this one. We told one patient, you eat only one chapati of 10 inches. But then he ate a chapati of 1 meter and said, still I ate one chapati. So I think these are all very important. The communications, and then the real complaints to the diet is again another big problem. They'll say everything we have done it. I think these are the standard. That's why the psychosomatic support is very, very important. Counseling, nutritionist role. I think it's a combined approach. Thank you.
Thanks a lot, sir, for a wonderful session. Next session will be on the topic Artificial Intelligence and Machine Learning in Hepatology, presenting by Dr. Ashok Chowdhury.
This is the land. The person who is filled up natural intelligence is only 85 kilometers from this place. So it is my foolish to discuss an artificial when the natural intelligence is so robust from this land. So you know the AI is expanding its tentacles and now it is going to be part of healthcare facilities. If you think of liver, the same thing, you go through as we are discussing, each topics are coming. I think it's a very vast topic, but I will cover few areas. You can say fatty liver, say cancer, say sepsis, say drugs, transplants, emergency, everywhere this has now shown its footprint. In following few minutes, just trying to say how it happens. So this is a journey, not very fast, it is very slow yet, however it speaks suddenly from 1952 to 2020. And it is just having a experience which has gone through the layers of filter to get a robust one, and the previously what we use is slow, descriptive and diagnostic, and how it has now changed to be an accurate, it is scalable, it is an actionable, and it becomes a fast, and from diagnostic and descriptive become a prescriptive and as well as a predictive. And this is simply a data science where you use a large data to get an accurate interpretation and hence little bit better than the conventional statistics analysis. So it is like a statistics, but it is added more of the confounders like we do in the multivariate, that we find 10% data to be taken. Here it takes all data to get an output. Hence it confuses lot of things. So as we discussed one by one, I will just cover limited areas. So fatty liver. So just see, this is, we know the gold standard, whatever MFLD or MS, the confused world. We use the parameters and to get accuracy close to 80% getting this. And see now a new thing has come as a fibrognostics. So this is study where they have used simple data, age, gender, BMI and few biomarkers, and it comes as a liver first as a predictive model. So the parameters are alpha 2, HAP2, these are the all blood based parameters. With this we can able to get a predictive up to close to 99%, both fibrosis activity as well as the steatosis. So if you go, this scale has come as fibrosis, activity and steatosis, and it giving a very interesting parameters what we can get through a biopsy. And this is now come up with a company like EcoSense, which has come with the FibroScan, and hope in future this fibrognostics is going to replace all these things with all parameters you can get. In FibroScan initially it is a fibrosis, then it is added steatosis, but still it is silent on inflammations, and hope this is coming in a big way. And this is already comes up and is commercial also. So it comes as a liver fast, liver fact and stato test. You can see, you can get status activity fibrosis. Now they have expanded to hepatitis C and B, and now they are getting the scanning. So this is coming up with a 99% accuracy, which we may consider. Then next important is what we are not able to do, the liver pressure. The liver pressure, you know, it is a very invasive procedure. You have to put a central line or you have to put a catheter for the femoral approach, you have to go for the machine, you have to read. And now this is the simply called as virtual epiphysiology. Here you do the CT, take the reconstructions, and you can able to replace the conventional way. And this is simply a model of computer vision. So you can see the similar way. You see the people's having varices, they progress to develop bleed. And we know these are the methods like red well sign, nipple sign, cherry red spots are the predictors for the bleed. But still these are not accurate, and if some patients comes to you landing with bleed, and you know whether this patient I should give beta blockers, you should give primary bending, and that is still you are not able to accept. If comes to me, I am interested more in endoscopy, I will go for EVL, I will try with the beta blockers, now it becomes a personal risk rather than any guidelines. I hope the house will agree. If a patient comes to with a large varices, the treatment is never as per the book. It is what we see or what we think. So this is going on, we can address or no. This is very interesting model that is called EndoAngel, where you can able to predict the risk whether this people is going to bleed or no. And here also they have taken same features what we discussed. This is just a computer vision. You just put the AI model into your endoscope. You get a prediction that this patient may bleed close to 90% accuracy in period of 6 months, and you can advise them for the banding. The next important is coming the liver cancer. You know liver cancer, I think everyone is aware of. It is now becoming the big problem because it's one of the cancer which is less treatable, and liver cancer treated by whom he has seen. Surgeon, radiologist, oncologist, everyone treat in the different way and is going on. But it is a very heterogeneous group. We know the standard intervention protocol is 6 months ultrasound AP, but we miss a lot. So because it is genetic, phenotypic, non-serotic, NFLD, lot of things are coming up which we are not able to see that it is a good surveillance protocol for early diagnosis to be treated, and that's why it is having high mortality. So this is very interestingly, you put a CT scan, you put some clinical laboratory data, and then you can get a retrospective data on how these people are going to develop SCC in advance and how it can be treated. And not only this much, for the diagnosis as well as prognosis, for the treatment, for the response, you can get the whole spectrum, good accuracy for this SCC. If you think of daily, every day we are struggling, we are given some medications, next day comes to us with a liver injury. How to go for? See, the daily is not a single spectrum. It includes your phenotype, your physiology, pharmacology, and it will need a whole of analysis to be taken into consideration before prescribing safe drug, and which is very difficult in our clinical practice to analyze. Hence, this has come up now, the drug bank. The drug bank is the data repository of the drugs which is called liver disease, and it's correlated to the features, the clinical parameters, where you can get close to 90% accuracy for this to get that what can be available. So with this, you can say these people's, that is called PTGS model, where pharmacogenetic models has taken into account all clinical genetic labs. They have made a data repository where you can get an accurate risk so that you can make a safe prescription to avoid delay, because these are the very untoward incidents which is very difficult to clinical practice where AI can help you. Then another important, you can think of infections, the critical care. See, infection and AI has expanded into this very interesting data. Obviously, it's not on cirrhosis, but it shows that if patients have sepsis or no sepsis, they have go through the various models, we can able to get an validation close to 82% of developing sepsis or no. And this parameters is very simple. You can see this is a very demonstrating way, and how they have shown, you can see simple parameters. Patients with sepsis, if hemoglobin, and it is pH, whether they are having blood potassiums, and with this are able to do a prediction of 81%. The simple put an algorithm. This is only one of the concept I hope we can combine, because it need a data in large numbers to get data on this. So infection sepsis can be improved by AI on diagnosis, sensitivity, response to therapy. We can make it customized liver based, and overall you can do the remote monitoring. You get the data, put your system, you can guide your team out for the treatments. Then next important is coming up is the language processing. You can think of hepatic encephalopathy. We know this is the grade which are using everyone, but problem with MHE. We know it is very difficult to diagnose. So most of the patients grow phase of MHE to overt HE, and obviously the overt HE a major group. So what you can do is just see the language processing. You process their outputs for this reactions, their voice, their speech length, speech frequency, and this is we are using daily. You see in your home Siri with you now. with Google Assistant, you are doing, most of the cab drivers are now not using any typing, just a voice. And you can see the Alexa is in your home. So this voice has been used and this has been taken and now you can see that if you put this, your voice to a cirrhotic patient, you can say that he is having likely hepatic encephalopathy or he is at risk of driving or is taking decisions. So this is how this area needs further exploration using NLP, that is severity, prediction, prevention, as well as hepatic encephalopathy tools. Then you come to the liver failure. You know the liver failure is a group where the peoples can develop SCLF, they can develop decompensation, or they remain persistent. We need a model which should be accurate and specific. So here we have developed a model. It is very large data, 6,000 patient data, and it is better than the existing models. You can say MELD and CTP. And this parameter is simple. A patient comes to you, he is having hepatic encephalopathy, yes or no. If he is, then see the INR. Then if INR is more than 1 point, he is having high mortality risk 80%. If his INR is less than 1.8, whether he is acute decompensation or is end-stage liver disease, then you see if he is having ACLF or end-stage liver disease, hepatic encephalopathy, INR more than 1.8, the mortality close to 80% in 90 days. So you can able to predict accuracy with 86%, you can expedite the treatment plan. If not having hepatic encephalopathy, if INR is less than 1.34, then you are comfortable to relax that this patient may be able to good things. Similarly, Nipunujit Me, he has developed a model on ACLF patients where you just see that creatinine at baseline day 7 circulatory failure, and he is able to develop model with close to 99% accuracy for these purpose. Then if a person comes to you with ACLF, whether he is going to develop organ failure or no, he is having stable over the time, you can develop a model where you can get close to 88% accuracy, and these simple parameters. This is the beauty that we are taking all parameters to get an accurate one. Just see the etiology, whether it is alcohol or no. If alcoholic, his BP is how much, and if his albumin is less than 2.8, he becomes a very high risk. A person of ACLF, alcohol etiology, MAP below 79, INR is more than 2.8, he becomes a very high risk. So this is just simple parameters, algorithms you can able to predict how these people are going to behave in these times. So prognostic models are already come up, Now you can think of liver transplant. It is also coming big way for all parameters you can say. Either you can predict AKI by simple models, you can see here, because you can save sepsis, you just from this monitor. Your vital monitor is in ICU, you can predict this person after transplant likely to develop sepsis 48 hours ahead. You see the beauty of this, hopefully needs treatment. And you can see that survival also you can predict a long way. Similarly about the rejection risk, you can say day 1, day 7 parameters, whether his rejection is going to happen, yes or no. If you think of metabolic syndrome, I'm going back. Though this is for the development of major cardiovascular events, developing diabetes after transplants, SCC recurrence after these transplants, and you can say the tacrolimus dose monitoring, how your patient is going to behave his tacrolimus level in follow-up also. They can make a model where patient can put data, you can give accurate results, guide them in further. So that means AI in transplant has progressed in all areas, pre-LT, perioperative, and post-transplant. With this, I want to say that the drawbacks, why? If I told that so much benefits, not why. It is because still not successful for many reasons, particularly accountable, ethical, and legal issues. Research is still done by separate people. Technologists think that way, clinicians think different way. We need a marriage of a medicine and engineering to get a good results which can helpful for the mankind. And insecurity till now, who will be heading this, and lack of validation in large centers with single centers. So dear friends, AI I can say it is necessity now. It is making out to be dependency. But however, we need a calculated balance to go ahead so that we can hear in conference and Dr. VGM can do endoscopy or he can go to move outside by help of this in future. Thank you.
Many thanks to Dr. VGM, as we fondly call him, for giving me this opportunity. The mandate given to me was to talk about clinical practice altering publications in GI and endoscopy, and I'll quickly try to take you through as many articles as I can. This was the first article I chose out of the multitudinous articles which appear, which is the waterfall trial. I'm sure most of us are aware of what the waterfall trial is. Technically, this is not a 2023 publication, but the first interim analysis came out in September 2022, and the final paper came out in March, so that it did qualify for the criteria which Dr. V.G. Mohan Prasad had said to me. And this particular landmark paper now talks about aggressive or moderate fluid resuscitation in acute pancreatitis. We all know, we have been taught from MBBS and MD days that early aggressive hydration is widely recommended in the management of acute pancreatitis, but the evidence for this practice is limited. This particular paper, interim analysis, analyzed about 249 patients, where the aggressive fluid resuscitation was given in 122 versus moderate fluid resuscitation given in 127. And the objective was to evaluate which was more safe, efficacious, the aggressive fluid management or the moderate fluid and acute pancreatitis was defined as per the revised Atlanta classification. So aggressive fluid resuscitation consisted of a bolus of 20 ml per kilogram of body weight followed by 3 ml per kilogram per hour. This is usually what we follow in clinical practice. Most of us use ringer lactate. As we all know, ringer lactate is better in the treatment of acute pancreatitis when you are dealing with hypovolemia. Moderate fluid resuscitation consisted of a bolus of 10 ml per kilogram in patients with hypovolemia or no bolus in patients with normovolemia. This was followed by 1.5 ml per kilogram per hour in all patients in this group. And when the results came through, the methods were like this, that they assessed the patient at 12, 24, 48 and 72 hours. And the primary outcome was the development of moderately severe or severe pancreatitis during hospitalization, and the main safety outcome was fluid overload. The planned sample size was 744, and this is the interim analysis which I am quoting right now. So a total of 249 patients were seen, out of which about 20% of the patients developed fluid overload in that subset of patients who received aggressive resuscitation. And it was found in 6.3% of those who received moderate resuscitation when you adjusted the relative risk. So suffice to say that it proved that non-aggressive moderate fluid resuscitation was superior to very aggressive resuscitation, which I have already defined as 3 ml per kg per hour given in patients. So this was the primary outcome, and if you look at the primary outcome, the fluid overload was significantly high. The severe pancreatitis outcomes were also more, and therefore it was concluded by this trial that the patients were nearly 3 times at higher risk of fluid overload in the aggressive fluid resuscitation group. There was no difference in the severe pancreatitis, organ failure or complications. The waterfall study has been criticized also, but I think this is a study we all need to be aware of, because if you look at the conclusion and the practice update which I would like this august audience to go home with is that it did show a definite improvement in terms of trying to be safer rather than sorry in terms of fluid overload when we used moderate fluid resuscitation vis-a-vis the aggressive fluid resuscitation. The second paper I chose is from Neurogastroenterology and Motility. This is about esophageal hypocontractile disorders and hiatal hernia size, which were used as predictors for long segment Barrett's esophagus. And this is coming from a research team from 3 major sites in the US and 2 sites in Mexico. It studied predictors of long segment versus short segment Barrett's esophagus. It analyzed factors such as demographics, Barrett's esophagus associated comorbidities, medication use, endoscopic findings, and presence of motility disorders. And the study included adults who met the 2016 American College of Gastroenterology guidelines criteria for Barrett's and subsequently underwent a high-resolution esophageal manometry between nearly 7 years gap. So this was a multi-center cohort study that included all patients with a diagnosis of BE who underwent HRM. Motility disorders were categorized as hypercontractile disorders or hypocontractile disorders, and their frequency was compared between patients with long segment Barrett's and those with short segment Barrett's. Multivariable logistic regression modeling was used to calculate the odds and of being diagnosed with LSB related to SSB. And very surprisingly, this particular study found that hiatal hernia and hypocontractile motility disorder increased the odds of long segment Barrett's by 38% and 242% as opposed to short segment Barrett's esophagus. Now this has a definite prognostic value, and this is something which we need to keep in mind when we see these patients who have hypocontractile disorders and large hiatal hernias. So the conclusion and practice update of this study was that the presence of a hypocontractile motility disorder increases the risk for long segment Barrett's, and the risk for long segment Barrett's is directly associated with the length of the hiatal hernia. Another paper, very interesting paper, which came out as a poster and later was published in ACG, is about ulcerative colitis, and this is about intestinal ultrasound, which is now an upcoming modality in the treatment of IBD, which is inflammatory bowel disease. Intestinal ultrasound combined to fecal calprotectin is effective to predict endoscopic mucosal healing in ulcerative colitis. This was a cross-sectional study. And in this treat-to-target era, the development of non-invasive markers, as we all will agree, is absolutely essential to assess endoscopic healing in ulcerative colitis. Fecal calprotectin, intestinal ultrasound are alternatives to colonoscopy to assess UC activity. A lot of patients are not very happy to undergo repeated colonoscopies, and for them, and even from a monitoring point of view and surveillance, this study carries a lot of significance. The objective of this study was to evaluate the performance of IUS and fecal calprotectin to assess endoscopic mucosal healing in ulcerative colitis patients. So this was again a prospective study, all consecutive patients between Jan 2021 and August 2022 with proven UC who underwent a complete colonoscopy, had an intestinal ultrasound and a fecal calprotectin. Within 4 weeks were included in a prospective cohort. Bowel wall thickness, BWT, and color Doppler signal, CDS, were assessed on each segment, and endoscopic mucosal healing was defined by a Mayo score. And again, very encouraging results were seen in this paper, which showed that a total of 57 patients were included. Nearly 58% had endoscopic healing. 32 were female. The median age and duration were respectively 43 and 29 years. Some patients who had a bowel wall thickness of less than 3 and an absence of colored Doppler signal were found to be in remission. The sensitivity, specificity, the positive predictive value and negative predictive value was matching with most of the existing standard of care. And this is what was found. The sensitivity, when you had a bowel wall thickness of less than 3 with a CDS of 0 and combined it with a fecal calprotectin of less than 150, the specificity went up to 94%, the positive predictive value was 89%, and negative predictive value was 48%. So the conclusion and practice update from this study is that the combination of IUS and fecal calprotectin can be looked at as a modality and is pretty effective to identify endoscopic mucosal healing in ulcerative colitis. In these days and times in 2023, we are looking at mucosal healing as the endpoint of treatment for IBD. And therefore, these non-invasive markers are something of great interest to all of us. I now come to the fourth paper which I have taken. I could have taken a lot of ACG and AGA guidelines, but I have just stuck to this one guideline because the idea is clinical practice changing publications. Guidelines keep appearing every year and guidelines keep changing every year, but these are papers which make us think and modify our practice accordingly. We have a lot of busy endoscopists in the audience here. So the American Society for GE has come out with a guideline on the role of ergonomics for prevention of endoscopy-related injury. We Indians tend to take pride in saying that we did so many procedures in a day, and this is the number of cases we handle in a week or a month or a year or whatever. But now we realize increasingly, just like you have repetitive stress injury due to computer overuse, endoscopists also suffer from endoscopy-related injury, which is a separate topic in itself in the West now. It is known as ERI. And this clinical practice guideline tries to address that particular issue. So this document was developed using the grading of recommendations, assessment, development, evaluation framework. So the American Society has now come out with these ergonomic recommendations, which are actually, if you think about it, it's a no-brainer. Most of us intuitively do this. You need your monitor at a level which is almost at your eye height, not your head height, your eye height, so that there is less strain when you are looking at it. Your posture needs to be erect. You need to do back stretches and have a gap between endoscopies. For those of you who are into therapeutic endoscopic procedures like ESD, EMR, POEM and all, which can take hours together, this is very, very important. The ASG recommends ergonomic education for endoscopists. The ASG recommends a neutral monitor position. The ASG also recommends the use of a neutral bed height. it suggests the use of anti-fatigue mats. This is something we all can easily implement in our endoscopy theaters. And it also suggests that GI endoscopists take micro breaks. I personally feel, forget micro breaks, take macro breaks after 2-3 procedures. Works very well and helps you prolong your lifespan as an endoscopist. Do I have some time? Yes. Okay. So another very interesting publication was this precise application of topical tranexamic acid to enhance endoscopic hemostasis for peptic ulcer bleeding. This is an RCT, and this is from a study which came out in gastrointestinal endoscopy. After undergoing standard endoscopic therapy, the patients in this study were randomly assigned either to the tranexamic group or to the standard group. In that tranexamic group, an additional 1.25 gram of tranexamic powder was sprayed endoscopically on the ulcer. Both groups then received 3 days of high-dose continuous infusion PPI, and a second look endoscopy was conducted on days 3 to 4. The primary endpoint of early treatment failure was defined as ulcer recurrent bleeding within 4 days or major stigmata of recent hemorrhage on the second look endoscopy. I think we are all well aware of the risks of this delayed bleeding in peptic ulcer patients. Dr. V.G. Mohan Prasad was the first in India to give me the hemo spray which he had developed. Unfortunately, the hemo spray, I come from Gujarat, is not easily available, and many a times we don't find it. So this particular thing we have tried in clinical practice, it works, and it's a good alternative when you don't have access to hemo spray. So 60 patients in this group, each with peptic ulcer bleeding and balanced baseline characteristics, were randomly assigned to a treatment group. Early treatment rate, failure rate was lower in the tranexamic group by 6.7% than in the standard group where it was 30%. The freedom from treatment failure periods for 4 and 28 days was significantly longer in the tranexamic acid group than in the standard group. No adverse events were reported. So this is exactly what I'm talking about. The tranexamic group, you do the standard hemostasis, which could be through some sort of a electrical pulse, after which you inject topical tranexamic acid at the site of the ulcer or around the margins, and compare it with the standard hemostasis where you just do a thermal ablation. So the conclusion and practice update of this study was that the precise delivery of topical TXA alongside standard endoscopic hemostasis reduced the early treatment failure rate in patients with bleeding peptic ulcers. If I just have quickly, this is the last, okay. So this is the last, we've been talking about bariatric, and bariatric surgery is now pretty much mainstream, and ESG is also something which has come up. We had a brilliant talk on AI by Dr. Chaudhary earlier, and this particular topic is on ESG reintervention score using supervised machine learning. So this is basically data from patients, large number of patients, more than 3,500 patients who underwent ESG in the metabolic and bariatric surgery accreditation quality improvement program. And it predicted a 30-day reintervention risk after endoscopic sleeve gastroplasty if you used machine learning. So the methods and cohort was that you selected the patients, did a multivariate analysis for ESG-RS generation. The results were, what are the factors which are influencing reintervention risk? It's a history of foregut surgery, preoperative ACUs, female gender, an ASA score of more than greater than 2, and hypertension. And the conclusion was that ESG-RS aids clinicians in preoperative risk stratification. This is very important because you need to select your patients well, and this is where AI will help us in the future to select the right sort of patients, and with machine learning it is going to get better and better in helping to identify patients at a higher risk of reintervention and enabling better decision making and patient management. Thank you so much.
About hepatology, so moderators, please let me know when the time is up. Okay, so I don't want to give you numbers, I don't want to give meta-analysis, but I will share a few very interesting research I read over the past 1 year. So I bring greetings from Amrita Hospital, and I have no disclosures relevant to this talk. So this is the breaking news as far as hepatology is concerned. Fatty liver, renaming, rechristening, everything, and now we are with MASLD. So many people have covered this, and Setu Babu sir had covered this in quite detail, so I will skip this. So this was the most promising thing that came out of on the NASH front. So this is resmetirom. Resmetirom is a thyroid hormone receptor beta agonist, which acts on the liver, decreases lipolysis and lipid toxicity. So they did 1:1 trial and one arm of open label resmetirom. And you can see that there is reduced hepatic fat from baseline compared to placebo. There was significant NASH reduction, significant fibrosis reduction, significant liver volume reduction, that is people who had enlarged liver because of fat, that also reversed. And also there was significant reduction in the LDL cholesterol, maximum up to 16% versus 1% in the placebo group. And the side effects were only diarrhea and abdominal discomfort. So this is one product which Madrigal Pharmaceuticals, I had the opportunity to listen to Stephen Harrison present this at EASL at Vienna. So they are going to market this and the phase 3 trial. This is a very promising research. The other one is from Dr. Rajiv Jalan's group. So where this is called as the Amon-Oichi model in cirrhosis. So they took 3 independent tertiary hospitals of around 400 patients, and they did clinical assessment, and they did psychometric test and also ammonia upper limit, and they tried to figure out who will develop overt hepatic encephalopathy. Very interesting study, and they found that the model called as Amon-Oichi model, which included ammonia, the sex, diabetes, albumin, and creatinine, this predicted the development of the first overt hepatic encephalopathy much better than your psychometric hepatic encephalopathy test and critical frequency test and other disease severity scores. So this was one study, and they validated the study as well. So ammonia is still important. The next one is a very interesting study. It's called as a pickle juice intervention or the pickles trial. So what they did was they took pickle juice and gave, as soon as you had onset of cramp, they gave at 2 to 3 teaspoons of the pickle juice. So basically, it's a very interesting mechanism. This is not their original idea. This was by a nephrologist who found that people who took pickle juice in patients with dialysis, who underwent dialysis and who had cramps, they had significantly lesser cramps. And the mechanism of action is very beautiful. So what they do is the acetic acid in the pickle juice will act on the pharyngeal receptors and then stop the firing of the alpha motor neurons, which causes muscle cramps. Very interesting study. Up to 62% of cirrhotics have muscle cramps, and it is one of the very vexing symptoms to treat. So it's a very simple intervention. So we can use this, and compared to the this study was done in the placebo group was tap water, not placebo, the control arm was tap water. So there was no difference in the sodium, no difference in the weight gain between these two groups, and the pickle juice contained a maximum of 75 mg of 75 milliequivalents of sodium. So this was a very interesting study, and now I am extensively using it in my patients after this study has been published. The next is from Jasmohan Bajaj's group. Everywhere albumin is being kind of bashed now. The ATTIRE trial, the ANSWER trial, the terlipressin trial, everywhere they said that the albumin is the one that is problematic and causing respiratory problems. So this, in patients with prior HE who have got cognitive impairment and minimal HE, they gave 25% IV albumin as 1:1 for up to 5 weeks. And they followed up for 1 week. And they found that the primary outcome improvement was cognitive performance. That improved, the social quality of life improved, and the most important thing is that the effect persisted even after albumin discontinuation. Very, in patients who are not transplant eligible or non-affording, you can, continue to give albumin in these doses. The next is when patients ask you, so now I have been recompensated, should I stop alcohol? So this is the study that gives you the answer. So what they did was 320 patients of alcohol-related cirrhosis, they did HVPG measurements. And they found that people who actively took alcohol had higher HVPG and higher risk of portal hypertension-related complication and decreased survival. So abstinence is related to decreased risk of decompensation, and improved survival. So this is one message that you can give your patients, that however far in the natural history of cirrhosis you are, there is still chance of recompensation if you stop alcohol. The next study, this is a clinical question that dermatologists and rheumatologists pose to gastroenterologists and hepatologists. They will send you for clearance for methotrexate, and you might have some AST, ALT derangement, AST of 56, ALT of 77. You don't know what to do. So this study says that irrespective of the cumulative dose of methotrexate or the duration of methotrexate, the fibroscan, there is no real fibrosis. This is a large study of 6 years of around 1,000 patients. So only factors which are linked to fatty liver like diabetes and BMI were associated with elevated liver stiffness. So you need not be worried about mild enzyme elevation while on methotrexate. This is another important point I wanted to drive home. The next is MR elastography for fibrosis estimation. So I thought we would have PGs here. So I just want you to remember these figures. So if you have MR elastography value of 3.14, it will correspond to F2, and 3.53 would be F3, and 4.45 would correspond to F4 or cirrhosis. So the only caveat while doing MR elastography is, one, if you have a GGT more than 120, or if you have significant steatohepatitis on biopsy, in these patients MR elastography can be wrong. So if you have an GGT of more than 120, better not to subject them to MR elastography for fibrosis estimation. You can see here that the BMI, the degree of steatosis or the presence of diabetes did not alter MR elastography, unlike fibroscan. This was an interesting study done at ILBS by Rakhi Maiwal's group. So in cirrhotic associated with septic shock, they targeted BP, two different targets. One was a high target of 80 to 85 MAP, and the other was a low target of 60 to 65 MAP. And they found that there is no difference in mortality at 28 days, but there were decreased incidence of intradialytic hypotension and at the cost of a bit more adverse events in the high BP group. So patients who are undergoing dialysis is the only reason where you would try to get a higher MAP of around 82. So this is another important point in sepsis patients. This was the other one of bepirovirsen in chronic Hep B. So we know that nukes and no treatment can give you only an HbSAg clearance of less than 1%. So this study published in NEJM, so this showed that when you give, this is a phase 2b trial, when you give 300 mg of weekly bepirovirsen for 24 weeks, there was sustained additional loss of 9 to 10% of HbS antigen and HBV DNA. And the only reactions were injection site reaction, fever, fatigue, and some raised ALT. So it was the phase 4 studies are undergoing now of bepirovirsen. So this is a new kid on the block. The next one is again by Rajiv Jalan's group on DiaLive. It's a very interesting study and a very interesting concept. So you see here, though they took alcoholic ACLF of grade 1 to 3, and they had 2 pass dialysis. One was a dialysis absorbent which would remove the dysfunctional albumin. So they found that in ACLF there are 2 main pathological forms. One is a dysfunctional albumin which itself is immunogenic, and then there is additional PAMP and DAMP, pathogen associated molecular patterns and damage. So they used 2 filters and removed both these pathogen causing, theoretically it sounds very great. And the thing is that it was very safe. So this was just a pilot study. So they found that they remove endotoxin and they shortened the time to ACLF recovery. And it is likely, that is the results were, though it was only 32 patients, it did not reduce mortality. So they're going to take up further, larger trials on DiaLive. So this is a next on dialysis front in ACLF. This is from our own group. Sorry to include one study from our group in PGI, because I found this very interesting. So what they found was in sick ACLF patient, we did in a single center study, all hospitalized patients, we did bowel, the rectal, nasal, skin, and the central line swabs for multi-drug organism. And we found that 70 to 80% of these people, patients, cirrhotics who were admitted in the hospitals had MDRO organism. And interestingly, at 28 days, we found that 80% of them got the same organism in culture somewhere else, and that was the reason for infection. So it is a worthwhile exercise to screen patients for MDRO colonization. So this was one study that we recently published in JHEP reports. This is a new concept, not very new, but still I thought I would say this. So in a decompensated disease, if you control the risk factors, precipitants, you can cause something known as recompensation. That is, you treat the etiology, there is resolution of ascites and HE, and there is no bleeding even for 12 months, you can call that patient as recompensation. So the definition of recompensation is sustained cure, suppression and removal of the underlying etiology, resolution of HE and ascites, and you have to discontinue all the prophylactic therapy and diuretics, and there should be no variceal bleeding for 12 months. So postgraduate students, you may get this as a short note. This is a very interesting article, again in JHEP. So now I'll just go on to few guidelines that have come. So these are on ACLF. So this is the EASL guidelines on ACLF. Here, important to note that they have converted patient group into stable decompensated, unstable decompensated pre-ACLF. This is from the PREDICT study by the journal Trebeca's group, and also from ACLF 1, 2, 3. And you can see there, their mortality is completely different. So it is worthwhile to calculate the scores of CLIF-OF and CLIF-C ACLF and prognosticate your patient. So this is a recently available guidelines on EASL. The other one is a guideline on intrahepatic cholangiocarcinoma. Now they say that you can divide into small duct type and the large duct type because the enzyme, the tumor marker signatures are entirely different. You will get IDH1, FGFR2 and BAP1 in here in the small duct, and you will have KRAS, MAD4 and TP53 in large duct. So I'm just finishing. So this is the treatment algorithm that they have proposed. So you can read this guidelines as well. And we have the INASIL HCC algorithm or the PURI 3 recommendation. It's very useful. It is not evidence-based, it's more of consensus-based, but it will help you stratify the patients into subgroups. This BCLC-B was a very heterogeneous group. So all of them you can select patients on this based on the INASIL guideline. So this is also another good one. And then again on the NAFL guidelines, you can look at the LSM, and if it's more than 13.6, you need to refer to hepatology or the gastroenterologist. 8 to 13.6, you encourage lifestyle modification. Less than 8.2, you can follow up. And vitamin E, pioglitazone, and saroglitazar are currently the available drugs. Okay, I finish. And on the flip side, we have some bad news as well. People's articles being retracted because of fraudulent data. This also happened in hepatology. So I finish. I'm open to any questions. Thank you.
Thank you, Dr. Arun.
Reading. So this is a 27-year-old who presented with black tarry stools since 2 weeks, admitted in a tertiary care center and resuscitated with Paxil transfusions. He had a CT angiography which showed he had multiple investigations and multiple interventions. I'm just highlighting it very short. So there's a focal short segment nodular arterial phase hyperenhancement in the mid-jejunal loop in the left side of the abdomen, suggestive of angiodysplasia. He also underwent a capsule endoscopy, and he also that also showed in the jejunum some amount of ooze was there. And he also underwent an angiography, and they could not spot the bleed on that. Then he had previous history of ASD closure in 2014, and during that time also he had bleeding, severe bleeding during the surgery, and he had a previous file showing a prolonged APTT of 48. When he presented to us, he was already partially resuscitated at a pulse rate of 98 per minute, BP was 110/80, and he was pale. Earlier in the outside hospital it was 6, and at our center the hemoglobin was 8.3. And because of the prolonged APTT, we did some hematological workup, we did a mixing study, and after adding the control the factor, we could find that he had mild hemophilia A. So after the mixing, before mixing study it was 51.6, after it was 36.8 after correcting it. And factor 8 level was low, mildly low, not severe. So he had mild hemophilia A. And we gave factor 8,500 international units 30 minutes before the procedure. We proceeded with the power spiral enteroscopy. So till now, they had even, I think they did everything, all the investigations, but they could not spot the bleed. They did a push enteroscopy, they did a colonoscopy. So then we proceeded with the antegrade power spiral enteroscopy. So what happened is, I finished reaching the cecum, still couldn't find the source of bleed, and there were some angiectasias which were not bleeding, and I did not, so instead of just giving it up and saying yes there are angiectasias, I felt that there was a significant amount of bleed. So I went in and out 5 or 6 times in the jejunum alone, and afterwards during the 6th time I could spot behind a fold there was a tumor actually, and it's a bit difficult to focus there because the mobility of the scope is only so much. So I'm clipping, there's a small gist or neuroendocrine, we don't know what, it had a clot on top, sitting on top, ready to bleed. So it was looking like a submucosal.
The CT angio did show enhancing lesion. I'm here.
Yes, it showed an enhancing lesion.
So
Yes,
it would suggest a
That
gist.
is why I went in and out of the jejunum. Initial multiple times the scope just flew past the area and we couldn't find it.
Most probably
so that is something we learned, that if we know a segment is bleeding, we should inspect it multiple times, like how we do a colonoscopic careful inspection of adenomatous polyps like that. Slowly I went in and out till we found this. It had actually stopped bleeding, but still we knew that he has hemophilia and can bleed again. So we referred him for further surgery, and but he did not undergo the surgery, and even the surgeons felt that we can wait, and for now he is doing good. So this is my case. Just
I think it's an intramural, most probably it's an intramural, just with a bleed into the lumen.
It's intraluminal.
Intramural,
yes.
with a mucosal component.
It's more of a, it's not a mucosal lesion, it's a submucosal lesion
exactly.
which is with a small ulcer or vessel on top, outside.
So I was just wondering how this, your local installation would help this patient, no?
We did a clipping, ma'am. So we did a deep, it's a large clip, it's the 16, I think no, even the bigger clip, the 17 millimeter with a thick jaw.
Any comments from the audience? Any comments?
Dr. Mehta, I have a comment.
Yes.
Sometimes even a duophile lesion may appear like this.
Absolutely, but this was, there was a proper submucosal swelling was there. I did not palpate it too much to disturb it because already it had stopped bleeding. And with limited motility, of the scope, movement of the scope, if it starts bleeding, then we'll be in soup. So I just did not, I just clipped it and came out. We were thinking of putting an endo loop around it, but I think it was not firing, so we went in with the clips.
So do you have a follow-up CT on this patient?
No, actually we referred the patient for further because he could only get operated in an institute which had factors. And so actually he went
if
to
it was
Vellore.
just, it is going to grow up and bleed again, right? Presence of hemophilia also. So we need to follow.
Absolutely agree with you that we need follow-up studies. But after that he went and then he did not undergo surgery. They stopped and they did not operate.
I think if we have AI software in these will be picked up.
Yes.
I think that will be an advantage when it goes behind the folds. I think that will come in a big way.
Thank you, Madhuram. Go for the next case. Just move on. Thank you. Wonderful presentation.
Thank you, ma'am, for the wonderful session. Next, presenter would be Dr. Vamsimurthy, sir, on the topic life-threatening GI bleeding after duodenal stenting.
Good morning, one and all. Actually, I'm only presenting this case on behalf of the big man. He's the one who did this case. So we had an elderly male who presented with abdominal pain and vomiting. It was an inoperable malignancy with gastric outlet obstruction. So we planned an enteral stent for this patient, and post-stenting, this is what happened. This is the endoscopy video, which showed narrowing at the duodenum. And we are trying to place an uncovered stent over here. Just we did a check endoscopy immediately after stenting, and we could see a gush of blood already in the esophagus and stomach. So we were surprised, this is something unusual. So we were going in and again inspecting.
So what do you think is the source of the bleed? Yeah?
I'll be showing it now.
Now, what was your suspicion when you went to it?
We had no clue why it was started to bleed.
We can't see the growth here. Growth is?
It is inside, beyond the duodenum.
Beyond the duodenum, is it? Okay.
So here we can see a visible arterial spurt. This is Professor VGM who is trying to use various gadgets which are available with us. Initially we tried clipping, and it was difficult to control this. So it's bleeding away from the duodenal stent area.
What could be the cause for this?
Forward. You can just keep moving. Just run through the video.
So even after clipping, we could, the ooze was not controlled. So we injected cyanoacrylate, and we could achieve hemostasis in this case. So immediately we could stop the ooze out there. This patient did well immediately after the procedure.
Do you think an interventional radiological intervention would have been a better option?
If endoscopic management failed, that is what we would have planned. Patient was doing well after the procedure, and hemoglobin was stable. So we only monitored him.
Every endoscopist, varicose bleed band ulcer is a nightmare actually, because there are no established treatments or guidelines. So I just present a 53-year-old diabetic person with liver disease who had varicose bleed a year ago. He was consuming alcohol at that point, and then following index bleed he stopped. But he presented a year later with 2 more episodes of varicose bleed, and he had hepatic encephalopathy. He was managed in a local hospital, with band ligation and sclerotherapy, and he was transferred to us for further management. Endoscopy, I'll show you the images. Endoscopy showed a large deep ulcer in the esophagus at 20 centimeters from the incisors with no signs of recent bleed. So all the parameters were relatively stable, so we didn't do anything. We just put him on some terlipressin, he improved, and then went home. However, a week later he was readmitted with a massive upper GI bleed, received units of blood, he was shifted to ICU, he was hemodynamically unstable. And then endoscopy showed active ooze from the esophageal ulcer, which we saw the previous week actually. So we didn't know what to do because it's not bandable, can't inject sclerotherapy, we didn't know the depth of the ulcer. One of our technicians said, like, why don't we use this powder we have? That's when I first came to know about this actually, and then we sprayed it on the top, and immediately the bleeding, everything stopped actually. And then optimal hemostasis acquired. So we brought him a week later, we continued to do that, and you could see that ulcer beautifully healed after a week. And then he went for liver transplantation because his liver tests were quite deranged, and he's doing well actually. After that, I'm quite fascinated by this. I started searching where this spray comes from. The technician said it's made somewhere in Coimbatore. I said I didn't know where it was made. So I tried searching, and then it's found it's an indigenous product of VGM. And then I contacted sir, let's do more work on this, and we even published this actually very recently on this. So we've been using since then on this powder. So you can enlighten us on, sir. So a little bit on that hemo spray.
Actually, this is a chemo seal spray. Thank you so much, Dinesh sir. That was like tonic for me. which the first case we demonstrated in 2011 from BGM in the ISGCon, so our workshop. So that is where we demonstrated the collagen spray. This is collagen, so which is made of triple helix. So it just immediately, like usually the collagen comes into action only on day 5 to day 7 when the collagen laying cells migrate to the area of abrasion. Whereas here we are, infusing or infiltrating collagen powder at hour 0. So it goes and immediately, smothers like a blanket, like what the chemo spray of Cook will do. At the same time, it's physiological. Immediately it triggers, healing. And it was, from Vellore group who said that it's because of this von Willebrand factor also in, projecting from some of these cells. They just absorb and then they also go down. Also, it just forms a matrix over which the platelets can come and adhere, and also the epithelial cells can start growing. So that is how it works in all, except for the arterial spurters. You can try. We have tried in almost like 20 indications. We have a collection of cases. So my appeal to all of you, whoever is using this Hemo Seed spray from Shaili, this is from Gujarat. So, I made them design it and then bring it out. So anybody who's using it, please collate the data, because still it's this research product and DCGA approval has to be gotten for this product. So please give us the cases so we'll all collate. We wanted to start with Dinesh Shodhimani, and also PGH Chandigarh is also using, and ILBS is using. We all wanted to start a group and start, going for a publication on this.
Good afternoon, everybody. Greetings from Triple M Hospital, Chennai. Thank you, VGM sir and Madhura ma'am, for giving this opportunity as a postgraduate to present a case. Just to keep the suspense alive, as this goes, the tale of a membrane. Here we have a patient who is Mr. M, 58-year-old male, who is a known CKD since 2010, on MHD since 2021. He had come with complaints of mild breathlessness over the past 1 month. HRCT has showed evidence of pulmonary Cox with syndemonic effusion and was started on ATT on 22nd of March 2023. Following scheduled hemodialysis on 29th, he had 3 episodes of vomiting and was not able to tolerate ATT drugs. The wife was the one who was giving history of retching in the patient. On admission after dialysis, he had 4 episodes of hematemesis of approximately 700 ml of frank blood. The patient does not give any history of passing dark or melanotic stools. Negative history is insignificant.
You can just make it brief.
Yes,
just tell us the highlights.
BP, yes ma'am. BP goes to 220 by 140. These were our differential diagnosis in the initial time, but when we have done the OGD scopy, we had something else in surprise for us. As you can see, there were membranous tissues which were in the esophagus, right from the proximal end up till the distal end. So we have done a relook endoscopy after transfusing 3 pints of PRBCs. We have done a CECT to rule out any mediastinal perforations. Relook endoscopy was done the very next day, and we had seen dark colored esophagus with a pseudomembrane, which was mostly of the mucosal membrane. And the distal esophagus, as you can see, EG junction was not affected. So the final diagnosis was acute esophageal necrosis, which is also called as a black esophagus. This is the video on the day of admission when we have done.
What is the cause and how did you manage the patient?
Yes, ma'am. So this is the membrane which I was talking about, and the black colored esophagus underneath that. So the pseudomembrane tissue was sent for HPE. We had treated the patient with IV PPI and with syrup sucralfate, and we had discharged him within a span of 4 days after stabilization. We asked the patient for a follow-up OGD after a month's time, and the follow-up OGD showed healed esophagus with normal, otherwise normal endoscopy. Now coming to the literature part, patients present with 66% with hematemesis and 33% of with melena. And classic AEN presents as diffuse black appearing esophagus in the distal esophagus that stops abruptly at the GE junction. Just to point out how rare a disorder this is, In a retrospective study in 1993, out of 80,000 endoscopies, the total number of AEN cases were only 16, which amounts to 0.01% in prevalence. And as you can see, the right side column where the prevalence is almost 0.01%.
It is uncommon. It's uncommon. Just move on.
Supportive care with IV fluids and PPIs is the treatment of choice. And one retrospective study which I've seen in 2021, which showed various treatment options which are possible. Most of them were treated with PPI infusions and blood transfusions. And the mortality rate goes as high as 33% in severe AEN cases. So, one of the few risk factors are diabetic ketoacidosis, drugs, like immune checkpoint inhibitors, and as well as it can be a post-surgical complication as well.
Thank you. Interesting case. Yeah, I think good learning points also.
Good afternoon, and thank you for giving me an opportunity to present my case. My presentation is on dilemma in upper gastrointestinal bleed. My case, a female of 52-year female, came with complaints of melena, one episode, with no comorbidity of diabetes, well controlled, and there was no history of any dyspeptic symptoms, and NSAIDs or any antiplatelet intake, no significant personal or any addictions or any family history. Patient was menopausal and there was no abortion histories. On examination, her pulse rate was around 90 and BP was 110/70 and pallor was present. The abdomen was soft and liver span was 14 cm with a splenomegaly of grade 2. With a basic routine lab of hemoglobin was about 8.8 with a total WBC count was around 5,800 and the platelet of 88,000 with a minimal derangement in the LFT and mild derangement in the and coagulation profile was also deranged with a 22 PT of 22 and INR of 2. On further investigation, we did an ultrasound which showed of prominent collaterals and a dilated portal vein of 14 mm, which was suggestive of portal hypertension. As the patient was hemodynamically stable, we shifted her for the upper GI scopy, which showed of a duodenal ulcer, Forest class 3, and Munilial esophagitis, and her H. pylori rapid urine test was also positive. So on basis of her upper GI scopy and Forest class 3, we started the patient on H. pylori eradication therapy and a post which followed by PPI therapy, and she even underwent a CT abdomen which showed again of splenomegaly and a paraumbilical, perigastric and paraesophageal collaterals were also present, consisting of the portal hypertension. The liver appeared to be normal with mild surface nodularity. We also did a fibroscan which showed of 31 kilopascal with a non-invasive markers of APRI and FIB4 of 1.5 and 5.63.
So what's the working diagnosis? Just move on. So how did you manage?
Key diagnosis was, the patient had on first...
Non-cirrhotic portal hypertension with GI bleed with a DU. Okay, next what happened?
Again the patient presented with another episode of hematemesis where we again did a upper GI scopy which showed of a development of portal hypertension with the ectopic varices near the ampullary area. But both were the portal hypertension gastropathy was mild, it was mild, so no active intervention. The patient was started on non-selective beta blockers as a further management and was advised to undergo a hematological autoimmune profile and a CT to rule out any obscure bleed from the ectopic varices. So
just carry on. Just carry on. What happened? What happened to the patient?
The patient was stable post starting with the non-selective beta blockers. So for further evaluation, for hematological and autoimmune workup and SOS liver biopsy to rule out any other cause of liver disease, the patient has to follow up.
So what's your learning point in this patient? What do you want to convey?
I want to convey is that even a portal hypertensive gastropathy can sometimes present as a bleed. And in this case, we were in a query that it's a cirrhotic or a non-cirrhotic liver disease.
This is classical non-cirrhotic.
This is a cirrhotic, yes, ma'am.
Thank you. Any comments you want to make? Just one comment, please. Just one.
So this varix needs endotherapy. Just beta blocker is not sufficient. Patient will definitely come back with a rebleed. We can consider glue for ectopic
We
varices.
counseled the patient for endotherapy, ma'am, but she was not willing at that present, so...
They'll land up even with tips maybe
Yes,
for
ma'am.
ectopic
Yes,
varices. Thank you very much. We move on to the next case.
Thank you, ma'am.
Thank you, Team VGM, sir, for giving me an opportunity to be here. There are two case presentations from my side. I will make things very simple. One, a young female around 30 to 30 years of old age who presented to us in the background of massive UGA bleed, finding more in favor of NCPF, in which we are planning for glue injection to the patient. And another case scenario in which isolated gastric varices we can able to identify, in which we are going to place a glue. And this patient findings in favor of pancreatic pseudocyst. And these two, and please go to the video. To place, actually, the prerequisites for glue injection videos. The prerequisites for glue injection, as we are well know, we need to take care of the anesthetic support, and moreover, the patient is supposed to wear the goggle and the aliquots. We need to make use of all the sclerosing needle. At least 3 sclerosing needles supposed to be ready when you are going to place a glue injection. There is either 21 or 23 gauge, whatever the things is available, and for more than 10 aliquots, usually 0.5 ml of sclerosing what you are going to use, inoculate glue, at least 10 cc of, 5 ml we need to make it available. And in one session, ideally, we can place at one point in one area, we can inject only 1 ml of the glue, and remaining maximum up to, there are some articles even up to 10 ml they have been injected, but usually more than 2 to 3 ml of glue injection will not be of much of benefit, as we need to look into evidence of embolic risk, which is predominantly will be happening in the pulmonary region. That's why we need to be very cautious with endotracheal intubation, monitoring vitals, all those things.
Doctor, what is it you want to tell in your patient? What is the message you want to convey?
Mainly the procedure of glue injection, what you are going to do, and how to monitor the patient and post glue injection. That's what
Fine. I think anything interesting in the patient that you want to convey?
Main thing,
the method of injection of glue.
Method of injection of glue, it should be in a rapid push technique. Ideally, we have been used Lipiodol in the initial phase. Now there is no much of role of Lipiodol, and we need to look for two major signs. One is catheter pull sign and red catheter sign. That two signs when you are going to look rapid push injection, and very frequently we have been experiencing that whenever you are going to inject glue, and even I have seen many patients where when I am trying to inject glue, sometimes it will clog into the surface. So it should not get happen. So rapid push and followed by distilled water and aliquot has to be given, and then we need to maintain a contact at least 10 to 15 seconds, and then we can remove that area to harden the polymerase of the surface. That's what the main thing.
Thank you. It's I think more of a technique that you want to convey. Thank you very much.
Thank you.
You want to
this case introduction also I present there. So this actually a wand, sir.
You want to present online, right?
So then you can
So you have prepared it so well.
Can you switch off the audio? I'll speak right now, no problem. So this is a young patient, 18 years old male, who had suffered from an idiopathic acute necrotizing pancreatitis a month back, admitted, had some organ failures, treated successfully and discharged. After 4 weeks of discharge, he came back with fever and sepsis, and cross-sectional imaging showed a large collection around 7 centimeters with necrotic debris inside, and he was clinically septic. And it was a single collection abutting the stomach and actually pushing the stomach up. It was in the peripancreatic region. So we decided to go ahead with the endoscopy guide, US guided cystogastrostomy. And since I expected the patient may require necrosectomy, I decided to put a Nagi stent in this case. So this is a procedure which I started. Now you can run the video. So it's a routine cystogastrostomy. So 19 gauge needle was used to puncture, tract dilated with cystotome followed by hurricane, and then the stent was deployed. The distal part of the stent I will is speak now. nicely So the opened inner, distal portion of the stent was properly deployed in a good endoscopic view. Now I have to deploy the proximal portion of the stent. So I request you to see the picture-in-picture for the endoscopic view. So this is an Nagi stent, it is not lamps. So the inner portion to be visualized. So I have seen the yellow marker. So now it has to be deployed. Now I am making a mistake here, that is why the case is here for discussion. So actually the stent should be little diagonal from the puncture site. It should not be tangential to the surface. Here I have kept the stent wrongly so that it is tangential to the surface of the stomach. So it should not be like this. There should always be a gap between the puncture site and the scope, and this gap should be horizontal and not in the long axis. So here maybe I was doing a mistake, that's why I am discussing this case here. So what happened, it is more tangential, and since I was sure about the yellow marker little away, nicely away, actually it was a 2 centimeter stent, about 1 centimeter is outside the puncture site. So I asked my technician to deploy the stent. I am sure in the endoscopic view it is nicely deployed, the inner portion is nicely deployed. So just good portion is outside the puncture site, so I asked her to deploy. So she was also enthusiastic. You can watch the EUS video now, what is happening.
So once I ensured that there is
Carefully
a
watch
good
the US
deployment
video.
of the distal end,
It just jump into
so I
the
encouraged my
cavity.
technician to
It will enter into the
deploy
cavity.
the proximal end as well. So when I was sure that I have seen the yellow marker, so I asked her to do
So-
It has gone
What has
inside.
happened?
So the saddest picture ever that we can have.
What
in
was
the-
your mindset that time?
So I was keeping myself calm. I can't do anything. Now the patient is in sepsis. Somehow I have to drain the collection. I can't put a new metal stent because patient has already paid for single SEMS. I can't give up SEMS from my scope room, which is not possible in a corporate center where I am working. I should only pay for a metal stent if I have to put again. So I decided to put two double pigtail stent. So I even thought of dilating the track and trying to pull the stent out, but I was fearing about perforation because lot of fear come in when we have complications. So I had to calm down myself and decided to put a plastic stent, and you could see I cannulated and I put two double pigtail plastic stents.
So this is
non-guide wire casing. Direct electrocautry enablement.
No, this is Nagi stent. There is a guide wire. So guide wire. So this after 2 weeks. So after putting double pigtail stent, the crisis was sorted out, and this 24/12. You can see after 2 weeks. I expect the track to be mature by this time. So went in after 2 weeks. Meanwhile, patient is stable, discharged in between, and called back after 2 weeks for a repeat procedure. Now I was still in a fear. I didn't want to lose the track. So first, what I did, put a wire inside the cyst cavity under EUS guidance and confirm with the fluoroscopy, and then I kept the wire aside and then removed the stents. So that I will not lose the track. So this wire in the side of the scope now. So removed both the stents and then dilated the track with the hurricane balloon, 10 millimeter hurricane balloon. I was again afraid here about dilating more to 15 millimeter, and then I went inside. As you see, the happy news is coming. I am able to see the SEMS well. It is just next to the site of puncture. Already all the fluid portions have already drained out as we expected, and patient is actually doing well clinically, in between discharge for 10 days also. So now I could see the proximal end of the stent, which is what we wanted. There are still some necrotic material, but the other wall of the cyst is well visualized, indicating the procedure was successful. So I decided to use the rat tooth forceps, catch the proximal end of the stent and bring it out. So there are still some necrotic material, so I thought I should not remove the stent and leave it off. Either I have to reposition the metal stent, or I have to remove the stent and place extra plastic stents. So I thought, okay, if it comes out well, good. It came out well. So this stent gently it was pulled out and it came into its exact position. So I reached my home. The stent said to me. So now I wanted to secure the stent. I did do some removal of necrotic material. I went inside that I have not included in the video for want of time. And then I cannulated it again and secured the position with the help of a DPT. So this was left there for next 3 weeks, and after 3 weeks later, I removed both the stents. This was done in December 22, and patient is now on follow-up and is doing well. Latest imaging shows no collection, and patient is fine.
A very good afternoon to everybody. I thank the organizers for giving me this opportunity. I bring greetings from Gangaram Hospital. So I'll be presenting our recent experience with a very unique foreign body. This is a foreign body that is a tablet with an intact foil, and interestingly in the last 2 months we came across 3 to 4 such cases, and we'll present what we changed. So initially in the first case, as usual, this was, we have a team of people doing it, and we try to do it the conventional way. Now mind you, this intact foil is not something which can be taken very lightly, and it is extremely sharp. It has a very sharp margin. So initially we tried to pull it out, but we could not do that. And then we tried to push it into the stomach, and then tried to wriggle our way out by maneuvering the scope here and there. But it was causing a lot of mucosal injury, as you can see, and almost nearing to causing a perforation. And we tried all our attempts, tried all angles, tried everything best we could. Eventually again pushed it back into the stomach. We could not get it out. Then we eventually also tried using an over tube, which we put into the esophagus, and then tried to pull it out. You will see that in the coming video. But there was no way that we could bring it out without causing a significant injury to the esophageal mucosa. So this was, then we used the over tube. Mind you, when we use the over tube, using and maneuvering a over tube is not very easy, and bringing it into the right axis so that you can align it with the foreign body is also not very easy. You have to wriggle your way a lot of times, and it made it really difficult and challenging for us to bring this foreign body out. And eventually though, we did get it out, but through the over tube. Yeah, so this is how it came out eventually. But if you see the endoscopy at the end, the check endoscopy at the end, you would be, it was a very morbid procedure, and there was a very high risk of perforation in such a case. So we contemplated how we could improvise, and we faced a similar situation immediately after a week, and then we did something very different. So this was the check endoscopy after this procedure was done. You could see extensive injury to the esophageal mucosa. Luckily, there was no perforation. So we realized that the challenge to retrieval were the sharp edges, quadrangular shape, and the cricopharyngeal narrowing, which was preventing us from bringing out. So in the next cases, what we did is, instead of trying to pull it out, we thought of how we could crush this tablet just like that, but we were not able to crush that with accessories. So the problem was the intact tablet within the foil, which was preventing the actual crushing of the entire unit, despite using all the accessories. So what we did is initially push this tablet into the stomach, and then we planned to dissolve the contents of this tablet. So, and we used our standard injector and flushed this aggressively with saline. And we were able to dissolve all the content within 10-15 seconds. So once now we have an empty capsule, and now it was very easy for us to crush it. We used an EMR cap to the endoscope, and now we could go in, grasp this basket, and now it was pliable. Now we could align it to the cap as we wanted it. It came in easily, and then eventually we could bring this out. And this we have been able to do consistently for 3 subsequent cases in the similar fashion. So, I mean, this was one of the small innovations, though it looks very small, but we found it very useful in preventing a disastrous outcome of a very seemingly innocuous foreign body, which, I mean, strangely we encountered 4 such cases in the last 1 or 2 months.
Congratulations.
May I start, sir? So, the next case I will be discussing was a case of biliary stricture. This was a post-cholecystectomy stricture, and we often encounter this in practice. The point of discussion is how far can we go with endoscopy in treating these strictures, and when should we say that now it would not be possible for us to do it endoscopically and go in for surgery. So this was a patient who presented with a post-cholecystectomy stricture, and it was a type 2 stricture with near complete cutoff of the CBD with presence of IHPR. So as you can see, the conventional cholangiogram showed a near complete cutoff. There was no contrast which was going beyond a point. But then very important thing that we do in such cases is do a balloon occlusion cholangiogram, where we insert the dye under pressure, and then we could see a streak of contrast going in after we did it with a balloon occlusion. So if you can observe here, so here you can see that this is the inflated biliary balloon, and you can see a streak of contrast going across, and it is an extremely tight stricture. But this being a very complex tight stricture, we did several conventional guide wire attempts, and we could not negotiate this stricture despite using the conventional technique for a very long period of time. So then eventually we decided to go in for a spyglass. So on a spyglass, we can actually see that the bile seeping out through a very tight stenotic area. But because of the anatomy and the angulation, our conventional Terimo guide wire, we tried multiple attempts, and we do have very skilled technicians with us, but despite trying very hard for a very long period of time, we could just not negotiate that area. There were probably because this wire was too pliable for us to actually get hooked there and go into that stricturous segment. So what to do next? So you can actually see where the problem is, and you know where the problem, what the problem actually lies, what to do next. So we tried multiple times, we could not do this. Luckily at that point of time, we had a very unique special guide wire available with us. So this was an 018 Nova Gold guide wire which was available. The advantage of this guide wire that we had at that point of time was the tip of this guide wire was relatively stiff. It was a gold plated guide wire. I don't think it is currently available. It was introduced by Boston for a period of time, and we thought that probably the stiff tip might help us just negotiate this bend and this angulation, and we might be able to hook it and go across. So as you can see now, this is the cholangioskopic vision, and now you can see that we were able to cannulate this strictured segment and then negotiate this guide wire across through this stenotic segment. Yeah, there it is. So after much effort, luckily it helped, and the fluoroscopy also confirmed that we could go deep into the intrahepatic ducts. The problem was that what next accessory could you use, because it was a very thin guide wire, and there was not much, because we could not dilate it because it was a very thick, very tight segment. So then we had to resort to using a 6-French cystotome. A 6-French cystotome is a coaxial cystotome. Now that we had a road map, we used this cystotome, and then using the cutting current, we went in and we could negotiate this cystotome well across, and then eventually use our conventional, exchange this guide wire for a stiffer guide wire, and then use our conventional dilators, and then eventually place in a stent with a good flow of bile. So the point was that if on a cholangiogram, if you are able to see that there is a segment across and there is some flow of bile, maybe using all techniques, you should be able to cannulate even the tightest of segments using your ERCP. Thank you so much.
Bethany, Banana. Mohan Krishnan also to join the panelists on stage.
So we all know ACLF is a vast topic. So when and what to do in ACLF, to cover in 5 minutes, it's impossible. So let's have a quick case presentation. It's a very local patient from Coimbatore. I thought we'll present him. It's a 39-year-old gentleman. Last year, this was alcohol-related acute on chronic liver failure. He was abstinent for 3 months. He developed ascites, jaundice. Things were not settling. Endoscopically, he had large varices. He also had some seizure disorders, so he came for further management to us. And that's a scan showing a very small shrunken cirrhotic liver, a lot of ascites. These are his blood tests. If you can see, followed here, total bilirubin 33 initially when he came in. Initially, it's sort of settling down, but again, things were not in the right direction. So we planned for liver transplantation for him. His wife was a potential donor. However, 2 weeks later, he was admitted very critically ill with septic shock, requiring double inotropic support. His creatinine from normal went up to 4.8, oliguric requiring renal support. Bilirubin jumped to 37, INR 4.3. So this is not an uncommon scenario for all of us here who are in the panel actually. because we do come across patients with acute on chronic liver failure developing septic shock and then just deteriorating. So he has liver failure, his kidneys are gone, he has got coagulation failure, he's got circulatory failure, literally all organ failure, what we classify as severe ACLF or ACLF grade 3 and above actually. His prognosis is, for example, when somebody has kidney failure, when not to do transplantation in ACLF scenario. What I felt is it's not very clearly established, but there's always a bit of confusion. If there is no improvement in GCS despite stopping sedation and the CT images are normal, then still you should not consider them for transplantation. Likewise, respiratory failure, why they have respiratory failure, whether they have ARDS, they may receive a lot of products, sometimes they develop a TRALI, transfusion-associated lung injury. Once again, you cannot transplant somebody if there is no improvement in oxygenation, if the PaO2 is, FaO2 is very high and no resolution of lung changes. Circulation-wise, increasing vasopressor support is in a very short duration, it's against going against transplantation. Again, we all discuss all this. The evidence is very less, particularly in ACLF grade 3 patients. Coagulation failure defined in APASL by more than 1.5, whereas in EASL it was more than 2.5. But once again, we can debate whether INR is a reliable marker of coagulation, because patients with ACLF are also prothrombotic actually. So this gentleman had typical grade 3 ACLF, but fortunately he improved. He didn't have a very severe organism. He had a urinary tract infection and E. coli in the blood, and he recovered and underwent LDLT in 2 weeks. But this is not the usual scenario because patients may not come out of all these things. So I thought I'll just finish here and we can discuss about when not to transplantation.
The fertility of transplant, generally the respiratory component, if it is there, I think that is a big no-no. Liver is okay, coagulation is okay, and
so that's what I was saying. So if you have more than 3 organ failure, generally patients should not be considered for transplantation, but which 3 organs is important? So if you're talking about liver, kidney, that's what I put. If you talk about liver, kidney coagulation, you're okay. If you're talking about liver, kidney, circulatory, you're still okay. But whereas if you're talking about brain, respiratory failure, then they are not okay.
I think
so these things are not very clearly established. But
ACL grade 3 we could still consider for transplant, provided he's not on a ventilator and he's not a diabetic, and if your GCS does not improve. If it's only circulatory, renal and probably coagulopathy, you could still consider ACLF.
And if they don't have active sepsis.
On a ventilator, diabetic patients, there should be some futility of for ACLF grade 3.
On ventilator support is important, whether due to encephalopathy or whether due to respiratory failure.
I think Dinesh, it's probably King's looked at their ALF and probably we will have to extrapolate what they use really. So renal replacement therapy continuously for more than 48 to 72 hours and an FaO2 increasing more than 60% and more than dual inotropes. That's what they decided, and obviously looking at encephalopathy where you highlighted that. And that's what they use for ALF, and that's the same thing that we probably would have to extrapolate for ACLF to see that when you decide not to proceed with transplant, and because this syndrome probably, when they have the acute hit, they primarily behave like an ALF as such. So I think the King's data would be extrapolatable for this one, I guess.
If you look at, on those lines, if you look at the APASL ACLF-R criteria, it's actually a combination of child skew score and ALF criteria actually. So that's how they are derived.
Either it's a ALF or ACLF or end-stage liver disease with other organ failure. To define this patient's not a candidate for liver transplant, number one, inotropes requirement. Those patients require the very less inotropes. For example, single strength noradrenaline, 3 ml, 2 ml if they require means okay. High dose of inotropes requirement, it's not at all a candidate for liver transplant. Second, ventilatory support wise, if FiO2 requirement is 60%, patient is not a candidate for liver transplant, irrespective of ALF, ACLF, or ESLD with ventilator support. And obviously sepsis plus. So here these patients recovered very well, that's happy. But if you see the first slide, double inotropes and the patient on the renal failure, there is no cutoff. So how I told the respiratory failure, FiO2 more than 60% contraindication, inotropes high dose or the double inotrope contraindication, but the renal failure alone, even though patient on renal dialysis, the renal replacement therapy, but still the patient is fit. That's why.
Absolutely.
In ACLF, if there's a clear-cut ACLF and renal failure, I think we should also initiate RRT provided we are able to bridge them definitely to transplant.
Yes. Yes.
Otherwise, there's a futility of using CRRT. If you, I think you have a donor by and then you can push the transplant in a week's time, I think then we can initiate CRRT. If there is not a situation like that, I don't know what is the role of CRRTs in these patients and how long do you continue?
Dinesh, interestingly, probably you would have seen a sort of a change of your practice. This one, you would have put in UK into a Liverpool care pathway.
So ultimately, most of these patients end up in a palliative care, but the acceptance of palliative care in our country is very, very reluctant. Patients are very reluctant, and the end of life care pathway is a big thing that has not developed in our country.
I'm sure all of us have seen one difference is the age. I think the reason why this guy pulled out, you were able to pull him out, was the young age. And that's something which we've seen. The moribund long-term ascites who's sarcopenic, we all personally see that more than 40 they struggle, and definitely more than 50 they struggle. So the younger age group, they tend to do well, and you can put your resources on that younger age group. That's what I've seen in
I think
practice in
comorbidities
India.
play a vital role.
Yeah.
Diabetes, obesity, and all those things play a vital role. Okay, thank you.
So good afternoon everyone. I've just given 5 minutes. There's tons to talk in nutrition, but I'll keep it as short as possible. So we all know that as a nutritionist, for me, malnutrition is the major concern in cirrhotic patients. So even in an ICU setup, malnutrition is something that we need to identify first, and we know that it's an immediate risk of mortality, which can be due to several causes. So these are some of the definitions of malnutrition given by several guidelines. So I'm not going to go through it. I'll just quickly go to the nutritional part. This is the prevalence and implications of malnutrition and sarcopenia and cirrhosis. So malnutrition is more frequently seen as a frequent burden in cirrhosis. So about 20% of patients who has compensated cirrhosis are malnourished, and more than 50% of patients with decompensated cirrhosis. So the progression of malnutrition is associated with progression of liver failure. We know that a patient who is malnourished has a poor prognosis in cirrhotic patients. So the pathogenesis of malnutrition and liver cirrhosis is that there are several causes, of course. So my major concern is the intake. So the decreased energy and protein intake. So that is one of the major causes of concern for me as a nutritionist in these patients. And mostly the reason behind decreased protein and energy intake is ascites, salt restriction. So salt restriction can actually affect the palatability of food, which can eventually affect their intake. Then micronutrients deficiency like vitamins, minerals, trace elements, loss of appetite despite increased ghrelin in these patients, and portal hypertension. So most of these patients tend to have a lot of GI related symptoms like loss of appetite, anorexia, vomiting, diarrhea, depending on what kind of drugs they are on. So it's important that we manage all of it. And so the first step as nutritionists, what we do is we do a screening, nutritional screening. So what subjective global assessment is the common nutritional tool that we use here. Even though most of the guidelines, they do suggest Royal Free Hospital global assessment. Subjective global assessment is also one of the advised screenings, and that's what we use in our hospital. So initially we do the screening to identify the patients who are at risk of malnutrition, and then from there we do a continuous assessment. So in our hospital we do an assessment in every 3 days to identify the patients and to monitor their malnutrition status. So these are the general guidelines, dietary recommendations in cirrhosis from different populations. So this is a summary of guidelines given by ESL, ASLD, ESPEN and other guidelines. So energy is recommendation in general cirrhosis patients is more than above 35 kilocalorie per kg body weight. In malnourished cirrhosis patients is 30 to 35 kilocalorie per kg body weight, and in cirrhotic patients with hepatic encephalopathy it's 35 to 40 kilocalorie per kg body weight. Now the guidelines, it is very beautifully written as to how the energy requirements are so high and everything, but in a practical situation it's not as easy to give them. Like definitely we can plan a diet with 35 kilocalorie per kg body weight or 40, even 50 for that matter. We can plan a beautiful diet, be it for patients who are on enteral feeding or oral diet, but the problem lies in the patients. I mean, because of their appetite or palatability, because they have a salt restriction, so they cannot, we give a salt free diet plus probably 4 or 5 grams of salt, which they can just add a pinch of it on each of their meals. So the palatability is affected tremendously and their intake also gets affected. So it's very difficult to convince patients to eat something. So we cannot just give them an extravagant diet and expect them to meet their nutritional requirements. So that's where a lot of counseling comes into play. So nutritional counseling is important in these patients, and especially patients. So there are two categories of patients. So patients who are on RT feeds, right, tube feeding or enteral feeding, or in those patients, yes, we can plan feeds, and their intake is definitely much better than patients who are on oral intake, because it's more, you just give the feeds through tube, so it's in our control what we give and how we plan the feeds. But the problem arises there when the patients are, taken out for procedures or some tests, so in between, so they miss their feeds and again they are not able to meet their nutritional requirements. So the problem arises when, so the thing is how we nutritionists work is during the daytime. So we have dietary department who prepares the food, but dietitians don't work round the clock. They are there in the hospital for a certain few hours during the daytime. So they give majority of the energy dense diets during the daytime and not during the night feeds. So what happens is when the patients are taken out for procedures or any tests, patient misses the feeds and the dietitian has no idea the patient is missing their feed, and then they might be missing the most energy dense or protein rich feed that we had planned. So there again their nutritional status gets affected. They are not able to meet their energy requirements and their they become even worse. So here what we suggest is we have a collaborative approach wherein the treating doctor and the nutritionist work together, where we are also aware when these patients have been taken for the procedure, so that we can plan the feeds accordingly during the times when they're actually going to be there in the ICU, and we can do that. Now in oral patients, patients who who can have an oral intake, the problem lies when they cannot eat. Their appetite might be poor. Their palatability of the foods, they might just not want to eat it because of the taste and look of the food, because in hospitals all they get is kanji and those kind of things, and most of these patients would be on a soft diet and not on a normal diet. So that again affects their appetite. So what we generally advise is instead of adding one pinch, which might be very difficult to do so, what we say is they can take maybe 4 or 5 grams of salt and they can add it in a little bit of water, mix it, and then they can add it throughout their meal so that it's more palatable. And there are also salt alternatives that they can use, like garlic powder, onion, then asafoetida, these kind of things which can have a salt-like taste but will also enhance their palatability of foods. So these are some things that they can do as general practical tips. Then protein requirements are about 1.2 to 1.5 in general cirrhotic patients. In malnourished and sarcopenic cirrhotic patients, it's 1.5 gram per kg body weight. In non-malnourished patients, it's 1.2 gram per kg body weight, and cirrhotic patients with hepatic encephalopathy, it's 1.2 to 1.5 gram per kg body weight. And there's no protein restriction, even if the, I'll quickly stop. So even if the patient has, hepatic renal syndrome. So we generally recommend a branch chain amino acid rich diet. So even the kind of protein that we give is rich in branch chain amino acids, so that they can digest it properly, and for the muscle to prevent muscle wasting. And also we include medium chain triglycerides as a form of fat for, again, better digestibility and also to increase the energy intake. And carbohydrates, we recommend a late evening snack with 50 gram complex carbohydrates. So again, this is to prevent further malnourishment and muscle wasting. And dietary pattern, it's like I said, we give a late evening maybe ONS or snack, which is an oral nutritional supplement, or a snack. And most of the oral nutrition supplements that we give are majorly focused on branch chain amino acids. So we give a supplement which is higher in branch chain amino acids. And with cirrhotic patients with hepatic encephalopathy, we give small frequent meals evenly distributed throughout the day, so that they can tolerate them properly. So no added salt diet is what is recommended, with additional 5 to 6 grams salt per day. And this, again, we should take care that salt reduction leads to reduced palatability. So we need to ensure that we are providing foods in such a way that their palatability is not affected. That's it. Thank you.
Senior resident in Department of Hepatology, PGI Chandigarh, and this is about an interesting case of bleeding gastric varices and shunt encephalopathy, a double whammy and an US rescue. So we have a case CAE recently published in American Journal of Gastroenterology this year, and this case is a part of it. Gastric varices can be encountered in 20% of cases with portal hypertension. The bleeding from gastric varices is less common as compared to esophageal varices, but is more severe and is associated with an increased risk of rebleeding and mortality. These varices pose a challenge in hepatology due to the risk of severe uncontrolled bleeding, as well as recurrent HE secondary to coexistent large portal systemic shunts that can be seen in around 80% of all cases. We present a case of a 50-year-old male, a case of alcohol use disorder, who presented with complaints of abdominal distension for 1 month, hematemesis for 2 days, and alternative throwing for 2 days. The initial parameters revealed the patient to be having anemia with thrombocytopenia and mild transaminitis, while the ultrasound showed features of cirrhosis. The patient had a baseline CTP and MELD of 7B and 13 respectively. An upper GI endoscopy revealed carpeted gastric varices in the fundus with evidence of small and lower risk esophageal varices. An endoscopic ultrasound was performed, and we can see a large conglomerate of gastric varix here. One of the feeder to this varix, that is short gastric vessel, was identified, and using a 19-gauge FNA needle, 2 ml of undiluted cyanoacrylate glue was injected into the feeder. The glue was injected in a direction opposite to that of the flow to minimize the risk of embolization. The Doppler beam thereafter showed reduced but persistent flow into the varix. Therefore, one more feeder to the gastric varix was also identified, and another 1 ml of glue was injected into it, which led to complete obliteration of varix. The patient reported no recurrent upper GI bleed, and the RT levels also became clear. The patient was hemodynamically stable. However, the hepatic encephalopathy was still there, despite of the fact that the bleeding had stopped. The patient continued to remain in persistent encephalopathy, despite of anti-HE measures, and it was somewhat disproportionate to the hepatic dysfunction during that time. We ruled out every possible cause of persistent grade 2 encephalopathy. The bleeding had stopped. There was no evidence of infection or electrolyte disturbances. The anti-HE measures were continuously being given to the patient. So we thought of an alternative cause for this continuous HE and suspected a portosystemic shunt could be a possibility. Cross-sectional imaging was done, which showed the obliterated gastric varix, along with extragastric shunt, which originated from the left gastric vein all the way down to the kidney in the left renal vein. Considering the possibility of a large portosystemic shunt as a cause of persistent encephalopathy in this patient, we decided to obliterate the shunt. Here we can see the large shunt, and using the 19-gauge needle, endoscopic transgastric shunt occlusion was carried out. 2 ml of undiluted glue was injected in one of the bends in the shunt against the direction of blood flow, which led to partial obliteration of the shunt, as we can see on Doppler. Here we can also see the glue cast, and using it as a nidus, another 1 ml of glue was injected, which led to complete obliteration of the shunt, as evident on the Doppler thereafter. A repeat cross-sectional imaging showed complete obliteration of gastrorenal shunt, which was evident on the previous CT. So, We can have various treatment modalities for management of gastric varices. These include direct endoscopic measures or IR-guided transvenous interventions or sometimes even surgery. However, the EOS-guided obliteration is one of the emerging treatment modalities for primary as well as secondary prophylaxis of gastric varices. EOS offers better delineation of vascular anatomy, with vision not being hindered by food or blood in the stomach. Moreover, the feeding vessel to the varus can be targeted to achieve hemostasis, and variceal obliteration can be confirmed on the table via real-time visualization of blood flow on Doppler. Similarly, for shunt encephalopathy management, the transvenous obliterative methods remain the standard of care as far as it is concerned. However, some of the recent data also suggest that even an EOS-guided transgastric shunt obliteration can be considered as a reasonably effective alternative to these IR-guided interventions. It not only reduces the procedure time, but is also relatively inexpensive. In addition, there is no fluoroscopy required. Multiple features can be targeted. It can be used as an alternative modality for shunt encephalopathy where there are technical or financial limitations. The cost was the factor in our case. So yes, EOS is an effective and possibly safe and minimally invasive treatment modality. It helps in better delineation of vascular anatomy as well as localization and targeting the feeder vessels to the varus. Moreover, it so appears to be an efficient modality which not only reduces the cost and procedure time, but it also usable in resource-efficient settings. However, the data is limited and high level of endoscopic expertise and familiarity with the vascular anatomy is required. Thank you.
Thank you. Dr. Sahaj Rati, Assistant Professor of PJ Chandigarh. He is an expert endohepatologist doing a lot of advanced therapeutic endohepatology procedures. And Dr. Arpit, both are there waiting for your comments and for discussion. This is, they were kind enough to give this case which they have already published. You can proceed, sir.
Arpit, please go on. Thank you very much. So this was an interesting and yet a complex case as in terms of management, as we considered the patient came with upper GI bleed with hepatic encephalopathy, which we initially attributed to the bleed itself, but later on found to be due to the shunt, a large shunt, which we expect when the patient has a large gastric varus. The patient was managed with endoscopic ultrasound-guided glue obliteration, and due to some limitations where in this case the cost was the limiting factor, we couldn't tackle the shunt with the standard measure, that is BRTO. So we offered the patient the EOS-guided transgastric shunt occlusion. That is an emerging thing. We have even published a case series recently in American Journal of Gastroenterology as well. And we tackled the shunt with the EOS. And the patient improved, the encephalopathy part improved. The patient, it's been around 3 to 4 months since the procedure has been carried on. The patient has been doing well. And yes, it's an interesting and good learning case in terms of management is concerned, where the EOS only the one of the emerging modalities of under hepatology or gastroenterology has tackled both the complications in this case, that is the bleed as well as the hepatic encephalopathy. So you are mute here.
So this was obviously not a routine case, and the decision making was not exactly straightforward, that the patient was not improving. The key point here was that the bleed had settled, the liver functions were not too bad, and the patient continued to have fluctuating encephalopathy, where we were able to rule out all the other causes of hepatic encephalopathy, rather mimickers of encephalopathy or other causes of encephalopathy. And that is when we finally took a decision, because this patient was fluctuating between grade 2 and grade 3. So this was kind of a difficult decision, but fortunately it panned out well. And it was the shunt that was leading to the advanced encephalopathy. If there are any further questions, I'm happy to answer.
So traditional IR related methods like the Part 2 or BRTO, so when we occlude it for the indication of hepatic encephalopathy, generally we should also look up for opening up of esophageal varices or development of ascites. So in this patient, did you follow up for that? Did it happen? Anything like that?
So yes, we did follow up the patient for that. Now this patient, for at least for the first 4 to 5 months, was doing okay. Came for the first follow-up and then again started imbibing alcohol, stopped coming for follow-up. And then just a few, couple of weeks back, we got an information that this patient had developed jaundice again and developed, alcoholic hepatitis and a bleed, because we were following up the patient telephonically. Yes, you are absolutely correct. We need to follow these patients up. We try to link him to de-addiction. We, in fact, have a de-addiction clinic right within our OPD, so the patient does not have to go anywhere. But unfortunately, the patient stopped coming for follow-up, and recidivism is a major problem. So that is we won the battle, but we lost the war, I guess.
Definitely the component of portal hypertension is there. It's just that we have blocked one vessel. It's going to present in some other way. It's just a matter of time. Thank you.